वरती जे आहेत ना,
Bhavik, the audio is not heard.
ऑडिओ इज नॉट ऑडिओ.
नाही आम्हाला येत नाही ऐकू नाही. हा
इथे ऑडिओ जर क्लिक केलं ना ते ऑडिओ नाही, तिकडूनच प्रॉब्लेम असेल ना राजेश.
हा
आवाज येत नाही, तिकडे येत नाही.
Bhavik, the audio is not heard. Hello, Bhavik.
भावेश
ठीक आहे.
आवाज होते की नाही.
शब्द कळतात.
हा चालू झालं.
येस. राजेश सर
हा
थोडं
बोला.
चहा इकडे पाठवा.
घ्या या शुअर.
ऑडिओ इज नॉट एबल.
ऑडिओ नाही येते. हवं.
Yeah, the audio is not there. गाण्याचा आवाजच येत नाहीये.
त्याला भावेशला माहिती आहे की नाही माहिती
मी
नाही.
करतोय सर, मी सांगतोय त्याला.
डॉक्टर जयस्वाल तुमची जयस्वाल सरांची 2 नावं दिसत आहेत.
नाही ते मोबाईल बंद केलं ना.
जयस्वाल सर, तुम्हाला एकातनं लॉग आउट करावं लागेल.
हा करतो.
राजाध्यक्ष जॉईन नाही झाले वाटतं.
सर मी फोन केला होता मग अशी आता पोहोचता येते.
बोलतोय बरोबर.
जस्ट घरी आता आले. ही जस्ट जॉईनिंग इन.
देगावकर पण नाही जॉईन झाले आणखी, ते पण येतील.
हो हो.
इंगळे साहेब नमस्कार.
नमस्कार.
आपलं गाणं लागलेलं आहे इथं.
हो, आवाज येत नाही हो ऐकू मला.
येत नाही पण हो ते संपत आलं तर आम्ही सारखं सांगतोय की तुमचा आवाज नाही येत.
देयर इज नो साऊंड.
शब्द आहेत शब्द.
राजाध्यक्ष आले वाटतं नाव. हो.
व्हिडिओ दिसतो
हा गुड इव्हनिंग.
काही
हा
गाणं ऐकू येत नाहीये.
आता आपण दिसतो.
मला पण गाणं नाही ऐकू येत म्हणून म्हटलं काय झालं.
अरे तुमच्या मनात ऐकलं झालं पाहिजे तुम्हाला.
आवाज ऐकू येतोय का माझा?
आवाज येते तुझा खणखणीत.
आवाज येतोय.
हा पिक्चर दिसतोय का?
नाही.
नाही तू दिसत नाहीस.
गिरीश भाऊंची आकाशवाणी होती.
काय
डॉक्टर पिंगळे
वडकमकर.
हो
मला दिसत नाहीये स्क्रीन समोर.
डॉक्टर पिंगळे तुम्हीच चालू करा.
शिरीष पण दिसत नाहीये. बाकीचे काही हे बरेच जण ऑफ आहेत म्हणजे.
माझा व्हिडिओ पण नाही दिसत आहे बघ. आता इकडे मगाशी लाईट होता, आता लाईट दिसत नाही.
इनकॉग्निटो आहेस तू.
Good afternoon. Can everybody hear me?
Yes, we can hear you.
We can hear you.
Hello. Okay. Good afternoon. I welcome everybody to this eMAPCON, the first online digital MAPCON being carried out since inception of the entire history of this conference. Of course, the times were trying, and therefore we this time couldn't do a physical conference. But I think some very like-minded people came together, and a lot of senior faculty supported the idea, and therefore we are all here today to have the first digital online version of MAPCON happening. I apologize for the map song because I was trying to coordinate with the event person. I think the audio file is difficult to be uploaded while sharing a screen. There's some technical issue he was describing. We apologize for that. But having said that, I think we begin. Dr. Devgakar is just joining us. I got off the phone with him also. So this is the inauguration function where along with the inauguration, we will also be doing a very, very important part of paying homage and condolences to the departed martyrs, the COVID martyrs of Maharashtra and India, specifically mentioning Dr. Bhoge, who was a very senior MAP member. So Dr. Rajadaksha will do that, followed by Dr. Mahavarkar, who is the organizing chairperson of this conference, and lastly by Dr. Devgakar, who is the convener. Then I will take over for the last few minutes, and then we begin the scientific program at 5 o'clock. So that is in short the flow of events for the next 20-25 minutes, please. So with this, I hand it over to the President of Maharashtra Association of Physicians, Dr. Girish Rajadaksha, please. Sir, Rajadaksha sir, you'll have to unmute your mic, please. Yeah.
Video is not seen.
Girish sir, you'll have to unmute. Now you have unmuted, but the video is still not on.
I don't know what is the problem. Just yesterday I was on Zoom and it was fine. I don't know.
Can you not log on from your mobile then?
Yeah, I will do that. 1 minute. Just a minute, please.
Sure. Dr. Devgakar also has joined us. I would request him to unmute and switch on his video as well, please.
Not able to see.
जाऊ नको थोडा अनुष्का.
पुढच्या वेळी पिंगळीने गाणं म्हणा.
आय थिंक सगळ्यांनी आपापल्या मुलांना बरोबर बोलून ठेवावं ही आयडिया बरी डॉक्टर देवकरांची.
इनव्हॅलिड मीटिंग आयडी येत आहे बघा.
तुला काय माहिती
इनव्हॅल्युएबल बाबा खरंच टीनेज मुलं.
बोलून घेतले तुम्ही देगावकर?
येस सर.
पुण्यावरनं बोलून घेतले वाटतं मुलीला.
मुलगी इथंच आहे. तिला बरं मला माहित नाही माझं हे का दिसत नाही व्हिडिओ रे.
व्यवस्थित दिसताय तुम्ही.
पण मी नाही मला दिसत नाही ना. अनुष्का थोडा वेळ थांब इथे.
त्याला बांधून ठेवा देवगावकर सर.
खाली निघून.
सर कॉन्फरन्सच्या एंडला अनुष्काला स्पेशल थँक्स द्यावे लागतील आम्हाला.
हो अनुष्का इकडे ये ना 1 मिनिट.
So now I can see you and I think you also can see me.
Yes.
अमित मला तुम्ही का लोक दिसत नाही रे?
सर
व्ह्यू मध्ये जा तिकडे आणि ते व्ह्यू मध्ये
जाधव सर चांगलं खतखतून हसून घेत आहे.
व्ह्यू मध्ये जाऊ का? व्ह्यू ऑप्शन्स.
I would request Dr. Rajadaksha to kindly begin. म्हणजे आपण we should adhere to time. आपण तोपर्यंत डॉक्टर देवगावकर will I request sir to figure out the view also. पण राजदाक्ष सरने सुरुवात करावी प्लीज.
Okay. So good evening.
तर तुम्हाला तुमचा एक डिव्हाइस बंद करावा लागेल. दोघांवरून लॉग इन केलं तर आयदर लॅपटॉप बंद करा किंवा मोबाईल वरनं कंटिन्यू करा. म्हणजे
आता
एक डिव्हाइस बंद करा सर. दोन्ही ऑन केल्यामुळे एको येतोय.
इकडे ना व्ह्यू ऑप्शन मध्ये काय असतं? मला माझा फोटो नाही.
बोला सर. देवगावकर सॉरी राजदाक्ष सर.
आता दिसतो पा मी सगळ्यांना.
हो दिसतंय.
I can see everyone.
Yeah.
Now it's okay. Amit?
Perfectly okay.
Is it okay, Amit?
Yes sir, perfect.
Okay.
अमित 6 महिन्यानंतर टाय घातली आज.
क्या बात है.
म्हणलं दिस इज द ओनली चान्स.
Okay. Good evening, everybody.
Good evening.
All the office bearers and managing committee members of the Maharashtra Association of Physicians, all the delegates, all the faculty members, chairperson, on behalf of MAP or the Maharashtra Association of Physicians, it's my pleasure and privilege to welcome you all for this first ever eMAPCON. And as you all know, we have to do eMAPCON this year because of the great pandemic, that is Corona pandemic, which nobody, none of us at least, have seen before. So it was the idea of one of the pillars of the Maharashtra Association of Physicians, Dr. N.G. Devgavkar, to have eMAPCON this year. And then we all supported that idea wholeheartedly. And Dr. Amit Saraf, our Secretary General, he took the lead. And what is going to happen over next 2 days is there will be the feast of knowledge about this Corona pandemic to all of us. Now, before this, I would like to pay my homage and salute the Corona warriors, all the doctors and other healthcare workers who have sacrificed their life, who have sacrificed their health, who have sacrificed the interest of their families to fight this particular deadly pandemic fearlessly. One of our very senior persons, another big support to the Maharashtra Association of Physicians, Dr. Bhoge sir, who was the head of the department of Maimar Medical College, Talegaon. He developed COVID. He was admitted for a long time in Dinanath Mangeshkar Hospital in Pune. And then he lost the battle and lost a great friend, philosopher and guide for the MAP. On behalf of MAP, I would like to pay homage and my sincere condolences to him and to his family. Om Shanti. That is what I would like to say on behalf of the MAP. Like Dr. Bhoge sir, many other physicians, many other general practitioners and many other consultants have lost their life in fight against this particular deadly pandemic. And there are almost close to 1,000 doctors who lost life all over India. And I think we should observe silence for at least 1 minute. I request by observing the silence to pay the respect to our Corona warriors who lost their life. So let us have a silence for 1 minute. So thank you. And now about this MAPCON, Dr. Mahavarkar sir, our immediate past president, Dr. Devgaonkar sir, our past president, and Amit Saraf, our Secretary General. These three people have taken maximum efforts, along with, of course, others, Dr. Jaiswal sir, and all of you have taken great efforts in the success of this eMAPCON. And as a president of Maharashtra Association of Physicians, I profusely thank everybody for supporting this concept and working hard to get sponsorships and to get delegates. Today, Dr. Amit Saraf told me that our registrations have crossed 2,300. That's a great number. And I hope all of them will attend the conference and all of them will be satisfied with the knowledge which is shared by very, very eminent physicians and very, very eminent experts in this particular conference. So with this brief introduction, with thanks to all the MAP members and thanking all the faculty members for accepting our invitation, all the chairpersons for accepting our invitations. Now I hand over the mic to Dr. Amit Saraf. Thank you.
Thank you so much, Girish Rajadaksha sir, our president of MAP. As usual, very succinct and clear in his thought content and very, very motivating and supportive in the entire endeavor. I would request everybody attending here that while somebody is speaking, to please put your mic and video on mute and silent and off video. So if somebody, the phone rings in the background or you talk, then that does not interfere and cause disturbance to the person who's speaking. So with that, I now invite the organizing chairperson, immediate past president, former president of API Thane, state RSSDI member, the chairman of the finance committee of MAP, very senior person and a senior physician from the city of Thane, Dr. B.K. Mahavarkar, to please say a few words.
Thank you, Amit, for your kind introduction. As an organizing chairman, I welcome all of you, including all my delegates, family, faculty members, and our MAP committee, core committee, and each and everyone who is attending this eMAPCON. Really, it is a brainchild of Dr. Narayan Devgaonkar, who thought that even though there are very, very few audience for the webinars, but he said that our audience is totally different. We teach all the physicians of Maharashtra, including rural and urban. They get updated knowledge of recent advances in medicine, their practical uses and management of the patients. So all of the physicians in Maharashtra are waiting for our MAPCON, because MAPCON has reached such a great height that whenever we call any faculty who is a national, international, they first think that MAPCON is very important than his other conferences or same is. So readily joined. Dr. Amit Saraf has done a very wonderful job. He personally invited all the faculty members.
Sir, mute झालेत.
So, Bhavik, Dr. Mahavarkar has become muted. Please unmute him.
Now you can?
Yeah, we can.
Yes.
Sorry, because I was just talking. And national and international figures of these faculty members are, readily accepted our invitation. We are very much thankful to them. Now I must thank Dr. Rajadaksha as a MAP president and organizing secretary of this eMAPCON for giving full support to the MAP to go ahead with this new venture. This is a virtual eMAPCON, and this is most successful with seeing the delegates 2,300. It will be a record for the MAPCON because we have not seen even with the routine MAPCON also 2,300. This is because of all the people who are working very hard, especially Dr. Degaukar, Dr. Amit Saraf is a key person who is managing all this show. We have to do very little, and we are there to, in spite of this good knowledge, academic fees, we have collected good amount for the organization. That is also a addition part of it. From my bottom of heart, I say best wishes to this conference for next 2 days. With this, I hand over mic to Amit Saram. Thank you very much. Amit, काय म्यूट झालंय का? What is this?
Thank you, Mavarka sir. I have spoken from the heart. Thank you so much, sir. You've been very, very academic map with dynamic, strong national faculty who's been on the governing body, who is on the governing body of the API, who's been the president secretary from Maharashtra, who's been present state secretary, national who's also the convener of.
Amit, तुझा इंटरनेटचा प्रॉब्लेम दिसतोय. I think there is some problem with Amit's internet.
Yes, sir, there's some problem on his end. It's lagging a little. So I think he'll log in again.
Is it a problem with him or is it a problem with us? I think
No, sir, it's his internet is
with
lagging.
Amit's
I'm back.
Okay,
Sir is back.
So
I think Dr. Degaukar can start his speech.
He is back. Amit is back.
sorry.
Amit is.
Sorry.
Amit,
So sorry.
Yeah, it's okay, no problem.
So छान दिसताय.
For me?
एकच छान दिसणारे सर हो सर.
Thank you for compliments. Good evening, friends. Actually, eMAPCON idea, which I got it from when I attended so many conferences which are online. And our association is a very old association. And the crowd which comes to this particular meeting is across the state, particularly people, physicians working in the taluka levels. So they need a good update. And nowadays, we are seeing so many patients of COVID. And in day-to-day practice, every day the guidelines are changing. So I thought, can update these people, because now the coronavirus has gone from urban area to rural area. And so many people from rural area, so many physicians from rural area, they are treating the corona patients. We know that the virulence of this virus has gone down. Infectivity rate also has gone down. Recovery has improved. In spite of all these things, we should know the updates, what investigation should be done, at what time it should be done, how should they be interpreted, and when investigations are done, how they should be treated. So when I talk with Amit Saraf, Dr. Rajadhyaksha, Mavarkar sir, and all executive committee members, Dr. Jaiswal, Ponpalle, Kelkar madam, and everyone, if suppose I am missing someone, sorry for that. But I already speak with so many people, I spoke with them, and they also had accepted this idea to have a conference which should be focused to the peripheral part of the our state. And we have got a very good speakers. Dr. Rajadhyaksha is working in the COVID ward since last 6 months. Since last 6 months, he has got a different experience. Dr. D.B. Kadam, he is also working. He is the heading Pune Task Force. So Dr. Shashank Joshi, all these speakers which have been invited and everyone has accepted our invitation. And the program which has been designed by Amit Saraf is wonderful. And he has given a focus on not on theoretical options. He has given focus only on practical things. how the patient should be treated. When patient means it is not only a theoretical approach, it is a practical approach towards the patient, and different guidelines, different drugs which are used, because we know that in COVID today, which drug works, the drug which works, next day it is banned because of some or other reason. So there are so many things, so many new things. We have got so many good speakers, and I think this particular idea of eMAPCON, because it is not possible nowadays to have a MAPCON directly, so we can have a virtual MAPCON, and there is a different crowd of MAPCON. I know I am attending MAPCON since last 25 years almost regularly. I have not missed a single MAPCON, and not there are so many doctors from peripheral area. They are attending MAPCON every year without fail. So these people should have some access to our different speakers from different parts of the country, and those who are the authority in this particular sector. That was the thing which was in my mind. And when I spoke to Dr. Mahavarkar, Rajadeksha sir, and Amit Saraf, they immediately started working on this. Amit Saraf, I will like to congratulate you because you have designed the program in one day single-handedly. He designed the program single-handedly. He has approached each and every speaker of his own. So credit goes of this CME, and CME points to Dr. Amit Saraf because he has done a fantastic job. I would like to congratulate him, and I would like to thank everyone, those people who have accepted my idea. Thank you again for my kind introduction, which has been done by Amit Saraf, and I would like to hand over the mic to him again. Thank you. Thanks a lot.
Thank you, Dr. Devgakar, for those kind words. It's actually, it's very, very, very wrong to say that it's been a single person. Everybody in that star-studded galaxy. I mean, I was going through every name and picture on the top bar of this Zoom. And believe me when I say this, that I think all stalwarts of Maharashtra are right here on this crossbar. I can see the founding president of MAPI, Dr. Alka Deshpande. I can see the national person who's worked in COVID area, Dr. N.K. Singh here. Dr. D.B. Kadam, Dr. Devgakar, our present president of MAP, Dr. Rajadeksha, Dr. Mahavarkar, Rajesh Patil sir, who was instrumental in starting the Award of Excellence in Internal Medicine examination is here. Dr. Pingde, who's been so instrumental in MAPCON coordination before, Dr. Joshi, Dr. Bhadkamkar. Without each and every person here this evening and this stage wouldn't have been possible. So all I can say that if it's thanks to me, it is thanks automatically to all of you. I thank you all for being here to make this event a very, very successful event. I would request every one of you as the core pillars of MAPCON to please attend the conference for both the days, today evening and tomorrow morning. We need you, your interactions, your discussions along with the faculty are most pertinent, and all of this is going archived on YouTube. So this is going to be a permanent record of eMAPCON 2020 forever, whoever logs in onto YouTube. Specifically, I would want to mention a few things here. Our event management, as it was a task in 3 weeks. I remember Dr. Rajadeksha cautioning us in the beginning that it's only 3 weeks for the conference. Will you be able to do it? So I believe Sohail and his entire team have risen to the task. I would specifically want to congratulate Sohail, Bhavik, Ahmed, who's been really, really working hard for the last 3 weeks to get this evening and tomorrow morning arranged. Thank you so much to them. To the extent that we were so popular, and Dr. N.K. Singh here deserves a special mention. He was the one instrumental in putting up eMAPCON on the CMEs of India.in website, which is a upcoming CME in India at a national level, which gave us a very big platform at a national level. And because of which, today in the 2,000 plus delegates, I am happy to announce that we have some 12 international delegates who logged on from Africa, Uganda countries as well, to attend this conference because they were very happy to see the scientific program on the national website. So thank you, Dr. N.K. Singh, specifically for this. I think any event is only successful with the kind of faculty and the delegate it draws. So I take this opportunity, as Dr. Devgakar said, it was not me arranging the program in a day. It was the banner of MAP. I had to only call up saying I'm calling up on the behalf of MAP, and people immediately agreed to talk on the behalf of MAP. So every faculty was absolutely thrilled, and it was an honor, I believe, to be invited by this prestigious banner and this prestigious conference. So it's all of us put together who has made this possible. And having said that, I conclude this inauguration ceremony by thanking each and every one of you to have logged in this evening. I would want to everybody to enjoy the scientific feast, which will happen this evening and tomorrow morning as well. And to begin the innings, our opening batsman, who's a star player, a hitter, who can score, many runs off the first delivery and the first over itself, Dr. B.K. Mahavarkar, who's been the immediate past president of MAP, and he's going to speak to us on a very, very, very pertinent and important topic of COVID and vaccination. And to chair that session, we have an equally dynamic person from the city of Thane, past president of API Thane, immediate past secretary. I have taken over reins from Dr. Rajesh Patil. I've learned a lot of the job of secretaryship from Dr. Rajesh Patil. He's been instrumental in the exam, which is so popular among the postgraduates. And because of Sir's effort, the MAP exam, let me again announce, has gone to a national level this year with Dr. Muruganathan taking it to the ACP, and I hope it goes to the international level next year. So with that, I hand it over to Dr. Rajesh Patil to begin with the first scientific session of the day.
Yeah, thank you, Amit. To begin with, let me remind you, about 1 year ago when we all met, assembled at eMAPCON 2019 at Navi Mumbai, we never thought that we will be meeting each other in this manner. All thanks to this COVID infection, COVID pandemic. And I don't see any hope of meeting all of us in person, at least for 1 more year. For we don't have any foolproof treatment or any other hope. The only hope which I see in foresight is the expectation that the COVID-19 vaccine may very well soon come on the horizon. Today, as an opening lecture, Dr. Mahavarkar is going to speak about this vaccination and in general. Dr. Mahavarkar, who is organizing chairman of this e-conference, doesn't require any introduction, as Dr. Amit has already introduced him. He is our past president of Maharashtra Association of Physicians. He was also organizing chairman of 2014, organized by API Thane branch, and he is at present in charge of the finance committee of Maharashtra Association of Physicians. I request Dr. Mahavarkar to deliver his lecture. Let's begin.
Thank you, Dr. Rajesh Patil, and thank you, Amit Rajadakshan Degaukar, for giving me the chance to open the innings. Actually, vaccination is a very vast topic and related with the COVID. So basically, can we give vaccination to the COVID patients or during the COVID pandemic? That was a basic to choose this topic. Nowadays, this is the hottest topic of the day. You can say that government yesterday announced 51,000 crores rupees for this vaccination in India. So yesterday we heard that volunteers from Brazil who were given the AstraZeneca and Oxford vaccination died during the testing. Nowadays, you know that vaccination can be in the society when you have a phase 1, phase 2, and phase 3. After completing phase 3, the vaccination comes into the picture. There are many clinical trials going on, but apart from that, I would like to start with what is vaccination. Vaccination, there are 2 varieties of vaccination. One is active and passive. And before that, I can say that with the 3 varieties, one is innate immunity, second one is acquired immunity, third is passive immunity. So what we always talk about is active immunity, which is produced by giving live, dead organisms or the toxin. The antibodies are produced time in days to weeks. So in emergency, sometimes we require antibodies, immunoglobulins or monoclonal antibodies in the form of passive immunization. So innate immunity needs to fight for the basic organisms. That is done by our macrophages, our acid formation in the brain, in the stomach, then complement fixation, lysosomal activity. So these are the these are the instruments from the body to fight for the organisms as an innate immunity. So then I start with my vaccination with there is no time to waste in the fight against COVID-19. No one is safe until everyone is safe. So with this, I start my presentation. Okay. There are certain recommendations given by WHO in respect to COVID-19 and routine vaccination. Should newborn vaccination program continues as planned during COVID-19 pandemic? The answer is yes. Given that institutional delivery should be maintained in the most situations, newborn vaccinations like BCG, OPV, and hepatitis B should remain a priority, and vaccines given according to the national immunization study. Second thing, is adult vaccination recommended during COVID-19 pandemic? Preventing respiratory illness and hospitalization from pneumonia, influenza, and pertussis through vaccination will allow respiratory healthcare workers to be more available to support patients with COVID-19. COVID-19 is associated with an increased risk of pneumococcal infections. Pneumococcal vaccination can prevent both primary and secondary bacterial infection and unnecessary use of antibacterial medication, that is antibiotics. Can a person with COVID-19 confirmed or suspected infection be vaccinated? The answer is yes. Today, there are no knowledge, the known medical contraindications to vaccinate person who have COVID-19. A confirmed or suspected COVID-19 not in a healthcare facility, example at home. Immunization may increase spreading infection to others. For that reason, the individual should defer vaccination until the symptoms resolve, preferably following 2 consecutive tests negative, that is COVID-19 conducted 24 hours apart. If the testing is not feasible, WHO recommends deferring vaccination for 14 days after symptom resolution. Now, can a person exposed to COVID-19 case be vaccinated? That is contact. There are no known medical contraindications to vaccinate person who have COVID-19. A person exposed to COVID-19 case is not a health facility, that means at home. This individual should first complete 14 days of self-isolation to prevent risk of COVID-19 virus transmission to others. If the contact does not develop symptoms of COVID-19 after 14 days of self-isolation, then this person can be vaccinated. Now, objectives, indications for vaccination, priority groups in vaccination, how to implement in practice. Now, I go back to the history. It is 1200 AD. Now, from very ovulation to earlier vaccination by Edward Jenner to modern vaccinations by Louis Pasteur to universal childhood immunization. Now, impact of childhood vaccinations, you know that tetanus was very deadly disease. It is well under control. Then you know that measles, the incidence of measles have gone down. The measles have gone down. Now the polio viruses like smallpox and oral polio has been wiped out from the face of the earth with the help of immunization. Nowadays, the adult immunization and children immunization, that means national programs are there for the children, but adults they don't have. But adult needs vaccination because, yes, there are 5 things to needs for adult vaccination. One is immunosense is with the sense. Immunosense with sense. Childhood infections in adulthood can be more serious. Modern therapeutics, cocoon effect of the immunization, herd immunity. These are the 5 things we need vaccination for adults. Okay. I'll start with the case presentation. 65 years old male, chronic kidney disease, not on renal replacement therapy. Baseline creatinine is 2.8. Regular follow-up with his treating doctor. Very religious about his medications, active social life, and takes care of his grandchildren. Complaints of acute febrile illness, coryza, myalgia, and cough. Fever settles after 3-4 days. 1 week later, presents to emergency room with altered sensorium, chest pain, and hypotension. Investigations on course, septic shock with pneumonia with multi-organ disorders. Ventilated, inotropics, renal replacement therapy, and prolonged ICU stay. Tracheostomy, secondary sepsis, 1 month stay in ICU, and lifelong maintenance hemodialysis. Economics of his stay in the hospital. Expenses incurred 15 lakhs. Cost of vaccination, flu vaccine is 900, pneumonia vaccine 1900. Vaccines are not just for the kids, they are for the adults also. Which vaccine to be given for the patients? That is flu, pneumonia, hepatitis B, hepatitis A, chickenpox, TDAP, MMR. Zoster, typhoid, Haemophilus, influenza B, meningococcal, human papilloma virus vaccine, rabies, yellow fever, Japanese encephalitis. It is not universal, but elderly, pregnancy, high-risk medically ill patients travel to endemic areas, stay for the students in the hostel, occupational health workers, veterinarians, forest officials need vaccination. Case 1, just I discussed with you, which vaccine would you recommend for the earlier patient? First is annual influenza vaccine, second is pneumococcal vaccine, and third is hepatitis B vaccine. Influenza vaccine available as trivalent, quadrivalent injectable vaccines or live attenuated nasal vaccine. Injectable vaccine is a subunit vaccine and strain changes every 2 years. 2 sets of vaccine every year, northern hemisphere and southern hemisphere is required. Now currently there are stage WHO recommendations for influenza vaccine in consideration with COVID-19 pandemic. To ensure optimal control of influenza among groups at high risk of severe COVID-19 disease, as well as influenza illness, the treatment in healthcare settings would increase the risk of exposure to SARS-CoV-2 and subsequent develop severe COVID-19. To decrease this potential for additive burden on healthcare systems from patients with influenza seeking medical care or being hospitalized, to reduce abstinence among the health workers and other care workers, providers essential to COVID-19 response, to ensure optimal management and use of potentially limited seasonal influenza vaccines. So influenza vaccine is very important to reduce the health burden and to give the support to the health workers to fight for the COVID-19. Highest priority groups, health workers. Other adults, like earlier, 2012 guidelines recognized the age was 65 as a high priority, but nowadays it has the recommendations to the state age is 50 years of age. Additional groups, if no other particular, it is not in a particular order. Pregnant woman, pregnancy suggests a potential increased risk of severe COVID-19 disease in pregnant women. Individuals with underlying health conditions, individuals living with type 2 diabetes, hypertension, HIV, asthma, and other chronic heart or lung disease. Children less than 5 years of age are not at increased risk of severe COVID-19. Risk of severe influenza, particularly those aged 6 months to 2 years. Countries that have procured specific formulation of influenza vaccine targeted for use in children, live attenuated influenza vaccines, should continue in this group. Timing of vaccination. North India demonstrates peak activity in winter and limited activity during rains. North Delhi, Eastern, Western India demonstrate highest activity during rains and limited activity in winter. Southern India demonstrate peak in cooler regions during rains. So these are the groups where we can give safely this vaccination. Timings. The WHO recommends the following for the northern hemisphere quadrivalent vaccines. For H1N1 and A Michigan 45-2015 like virus. For S3N2 and A Singapore INFIMH 16-019-2016 like virus. For Victoria and for B Yamagata. These are the 4 strains. Efficacy of flu vaccine. Efficacy varies depending upon circulating strains. Most important to know its effect in preventing hospitalization and severe disease. Preventing flu means preventing invasive pneumococcal disease. Efficacy of flu vaccine. Influenza vaccine modifies disease severity among community dwelling adults hospitalized with influenza. Influenza vaccine is associated with reduced severity of community acquired pneumonia. Vaccination does not mean that there won't be infection. Protection is not absolute. Contraindication of influenza vaccines. History of Guillain-Barré syndrome following vaccinations. History of severe anaphylaxis with vaccinations. And egg allergy relative contraindication. but mostly 99% there is no contraindication for any vaccines. The vaccine gives more protection than the non-takers. Okay. Pneumococcal vaccines. There are two varieties of pneumococcal vaccine. One is conjugate PCV13, more immunogenic, can prevent colonization. Non-vaccine type pneumonia is not protected. Polysaccharide, that is PPV23, less immunogenic but covers most of the circulating strains. At the age of 65 or older, immunocompetent, a dose of PPSV23. If PPSV23 was administered prior to age of 65, administer one dose of PPSV23 at least 5 years apart from the previous dose. At age of 65 and older, immunocompetent, one dose of PCV13 based on shared clinical decision making. If both PCV and PPSV23 are to be administered, PCV13 should be administered first. The PCV13 and PCV23 should be administered at least 1 year apart. PCV13 and PCV23 should not be administered during the same time or same visit. Age 19 to 64 years with chronic medical conditions, chronic heart excluding hypertension, lung or liver disease and diabetes, alcoholism or cigarette smoking. One dose of PPSV23 is sufficient. Age 19 years or older with immunocompromise, one dose of PCV13 followed by one dose of PPSV23 at least 8 weeks apart. Then another dose of PPSV23 at least 5 years after the previous PPSV23. At the age of 65 years or older, administer one dose of PPSV23 at least 5 years apart. Most recently PPSV23, only one dose recommended at the age of 65 years or older. Now, hepatitis B, purified major surface antigen by recombinant DNA technology. Adult dose is 1 ml 20 micrograms intramuscular. If associated with CKD, it is 40 micrograms. Scheduled dose is
Dr. Mahavarkar, we have 5 minutes more.
Okay, thank you. Scheduled dose is 0, 1, 6 months. Anti-HBs levels post-immunization is more than 10 international units. Varicella vaccine 2 doses 1 to 2 months apart. Contraindicated in pregnancy and immunocompromised host. Can be used as a exposure prophylaxis in an exposed vulnerable immunocompetent host. Vaccine efficiency is after 2 doses almost 100% preventing severe infection. Mild breakthrough varicella infection is known in vaccines. Okay. What are other vaccines in a healthy elderly? Indicated above 50 years of age. Live vaccine with higher concentration of varicella virus. A new subunit vaccine available from this year prevent post-herpetic neuralgia. Now case 2, 29-year-old RMO working nursing home with needle stick injury. Previous vaccination status not known. Which vaccine do we give? TDAP, hepatitis B, documented anti-HBs levels. So other important vaccines in healthcare workers is TDAP, MMR, varicella and flu. TDAP preferred over TT. TDAP is replaced TT. It has a TT, DT and a cellular pertussis. For adults, one dose of TDAP followed by TD every 10 years. Contraindications, encephalopathy related vaccines. It's very rare. Case number 3, pregnancy lady, 3rd trimester. TDAP, one dose is sufficient. Flu, TDAP, next, TDAP, flu. One dose of TDAP during each pregnancy and during 3rd trimester. Who actually TDAP, who anticipates or have a close contact with infants aged less than 12 months of age to protect against the pertussis. So TDAP is indicated in MADA. It is advisable to replace TT with TDAP in our practice. Now hepatitis A. Severity of hepatitis A is age-related and fulminant hepatic failure often leads to that. One dose booster is 6 to 12 months later intramuscularly. Indications, chronic liver disease, high risk behavior, close household contacts and endemic area. Place number 4. Teenagers touring abroad for studies. Which vaccine? Hepatitis B if not received. Human papillomavirus vaccine, meningococcal vaccine. The human papillomavirus, highly purified virus particles, that is major capsid L1 protein, oncogenic HPV 16 and 18. Schedule timings for the vaccine is 0, 1, 6 months. Girls, the year is 11 to 26 years, boys 11 to 21 years. prevents cervical cancer, genital warts, anal cancer due to vaccine-directed strains of human papillomavirus. There are three varieties. Quadrivalent is Gardasil, bivalent is Cervarix, and third one is 9V. Then meningococcal is quadrivalent ACYW. College students living in the hostels, inmates of military barracks, workers in hostels, and stomach patients are needed this meningococcal. Extrahepatic pulmonary
Dr. Mahawkar, we are short of time. Will you wind up, please?
No, that's it. Okay, this is very vast, but I will wind within no time.
Yeah.
Pneumococcal vaccine, meningococcal and Haemophilus influenza B vaccine. H influenza usually not recommended in adults, indicated only in schizophrenia, HIV patients, and undergoing splenic form. Travels, harsh, safari, typhoid, rabies, cholera, and yellow fever. Now, just I'll mention typhoid vaccine. It is given along with the tetanus toxide, and it gives immunity 5 to 7 days booster every 3 years. Next, cholera vaccine. All recommend travelers to cholera endemic area. Oral dose, 2 doses, 7 days apart. Others are Japanese yellow fever and yellow polio. Rabies vaccine, pre and post exposure prophylaxis. Pre exposure in high risk individuals with occupational risk. Post exposure should be recommended with passive immunization with anti-rabies immunoglobulins or monoclonal antibodies. So this is a chart which is what I told. Next chart is like this. This is CDC chart, Central Disease Control Program, and it is same what I told. Now the vaccine watch, which we are thinking about the pandemic. There is a Covaxin, Aurobindo Pharma, biological. Vaccines are in clinical trials. And you know that phase 1, phase 2, phase 3. You must have heard about the Sputnik V from Russia, Sputnik, Moderna from USA, Vitek Pharma, and then Zydus, then then Zydus, and Sputnik V, BTNT 160. These are and Pfizer, Indian Immunological Griffith vaccine. So these are all vaccines which are in pipeline. We don't know what is indication, contraindication, but they are on the pipeline. Like smallpox, we hope that with the vaccination, this pandemic COVID-19 will wipe out from the face of the earth. So we hope and we welcome the new vaccine. And with this, I just stop here. It was a very vast subject. I could cover whatever it is possible for me. Thank you very much.
Thank you, Dr. Mahavarkar. You have taken us all from our college days to the current vaccination, what we have learned. It was indeed an informative lecture. Just at least we can say we have just rewinded our knowledge of what we were to know. The current vaccine which are available, you have given us a brief view of what are the things which are available. I don't think so there are any questions. There are no questions as yet. So I think we can conclude this.
Can I ask one question, please?
Sure, sir.
It has been believed that because of BCG vaccination, the incidence of COVID in India is much less. And Mr. Sharad Pawar had just taken BCG vaccination. It was in the newspaper. Is there something called as booster dosing of BCG vaccination?
It is not proved that BCG helps in pandemic. So it is a rumor and it has no relevance with the BCG booster or BCG dose. WHO says only one study, nothing can be conclusive. So WHO did not give any importance to this BCG vaccination, and there is no positivity found in during any study.
Even there was a rumor about MMR vaccine also. I don't think so there is anything truth about it.
And okay.
Okay, yeah. Thank you, Dr. Mahavarkar, for this lucid lecture. Over to Dr. Amit.
Thank you. I think Bhavik, you can please continue.
Yes, sir. So for the next topic, COVID-19 and clinico-pathological correlation between pathological test and clinical status by Narayan Devgaonkar sir, I would like to call Dr. Vaishali Lokande She's a consultant physician with Apollo Hospital, Nehru, and she's the joint treasurer for the MAP committee as well. Vaishali ma'am?
Good evening, everyone. Namaste from Navi Mumbai. We know that the vaccine is going to come anytime soon, but till then, I guess all of us have to make do with what's available. How to deal with the case of COVID? Look at the clinical pathological correlation. So for that, we have the topic to be spoken by none other than Dr. Narayan Devgaonkar. It's a pleasure to introduce sir. He is an FRCP London. He's a eMAPCON coordinator. He was the organizing secretary of RSSDI 2020 National, honorary secretary for state chapter RSSDI Maharashtra. He was the past president of the MAP, organizing secretary for MAPCON, RSSDI and Indo-US Emergency Medicine. He is also the joint secretary of Indian College of Physicians, the Dean's Place. He is a former member board of studies, PG Medicine and allied subjects with the MUHS. Over to you, sir.
Just a minute, madam. I'm just loading the slides. Good evening, friends. Can you hear me? Yes, ma'am?
Yes, sir. We can hear you.
Yes, sir.
Yes, very much
Slide
clear.
seen, well heard, no problem.
Yes. Thank you, Dr. Amit. Actually, this is a very important and clinical topic which you have been given to me. Actually, as we know that COVID infection since last 6 months, everything is changing day by day. The thing which works today may not work after a few days. And there are so many literatures coming, so many studies coming, but none is specific yet. There is not a clear, till this date, there is no specific treatment for COVID, that all of us know that. And actually all of us are treating COVID patients. But in spite of all these things, as Mahaurkar sir said, because we are already, or Jadhav sir already said that this BCG vaccinated people we are, so we are less likely to get infected. So because of that, or I don't know what is the reason, but the mortality rate is very low in Indian context. Even just a minute, the mortality rate is also low and recovery rate is very fine in India particularly. Actually, as far as COVID is concerned, what investigations we are supposed to do and how to interpret these investigations is very important, because there are so many investigations which are coming in practice. Some investigations are very costly. Some people are not affording. At some centers they are done. At some centers they are not. People are not able to do it. So what investigations are important and how to correlate it clinically and medically also to treat the patient. So I will share the slides. Actually, my talk will consist of initial the symptoms of COVID. Then I will cover different investigations, then clinical pathological correlations of these investigations to different systems. We know that COVID, most of the patients of COVID are presenting with fever. Fever is a very diagnostic symptom as far as COVID is concerned, because in this context, particularly in this pandemic, when the patient of fever comes to your clinic, we always suspect that this patient, whether he has got COVID or not, or we are very cautious about him. We send this patient sample for RT-PCR or antigen testing. Then another important symptom is fatigue. So many patients comes to your clinic with severe pain in body ache, severe body ache, not responding to any analgesic. Few days back, I have seen one patient who was not responding to analgesics. I was to give him steroids. But anyhow, if I tested him for COVID, after 2-3 days, he was turned out to be negative. But we don't know exactly whether he was COVID or not. We know that even RT-PCR test in 38% of patients initially are negative. So when RT-PCR tests are also to be done, that is also important. Then patient has got chills almost in 11%. Then there is a new symptom which has come described by in the US initially. It was a loss of smell and loss of taste. But nowadays it is seen in almost 75% of patients. The patient has got headache, nasal congestion, then sore throat, which is very common in these patients. Those patients get dry cough, not with expectoration. Productive cough is less common than dry cough. Then if the patient gets deteriorated, the patient becomes dyspneic, then patient has got vomiting. If the gastrointestinal tract is affected, patient may get diarrhea. then muscular pain. There are so many patients, 10 to 35% of ICU patients show cardiac abnormalities also. But there are different systems which have been affected in patients of COVID. Lungs are affected, heart is affected, kidneys are affected, neurological patient may get stroke. Then patients are presented with diarrhea and nausea so many times. Then endothelial cells are also affected, causing lupus and lupus disorders. So how to interpret this thing? Timing and interpretation of the investigations is very important in COVID patients. So what are the basic investigations which we are doing in day-to-day practice? We know that any fever patient comes to your clinic, we advise him to do a CBC. CBC is supposed to be the most important investigation which has been advised in all patients of fever. So is it sufficient to do only CBC, or we have to advise so many things? And what interference we are going to get it by doing CBC? There was one article which has been published in US. It was in one of the universities. They studied 50 patients of the COVID, and they found that there is a zero eosinophil count in these patients. Out of 50, 38 patients had a zero eosinophil count, and remaining 12 had a low eosinophil count. So eosinopenia, we know eosinophilia, but we are not very much acquainted with the eosinopenia. If the eosinophil count is very less or it is zero, the prognosis in patients of COVID is supposed to be the worst. This is a very important take-home message from this. Patients of COVID gets low eosinophil count, and if the count is less, the prognosis is worst. Then we always think of doing a neutrophil and lymphocyte count. In these patients, virus, we know that virus first attacks lymphocytes. Either it is T cell lymphocytes or it is B cell lymphocytes. Once they attack the lymphocyte count goes down. And we know that neutrophil to lymphocyte ratio is 2:1 in most of the cases. It has got a more of prognostic value than a diagnostic value. Initially, actually, there is a 2:1 ratio, but if the patient has COVID, patient is deteriorating, the lymphocyte count goes down low and low. So the ratio becomes high. It is 3:1 or more than that. The third important thing is platelet count, which we are doing in all these patients. We are very much acquainted with the platelet counts because of this dengue fever. We know that all patients of dengue has got platelet count initially going down, down, down. Even it reaches to up to 10,000 or 5,000 also. But we are not bothered because we can treat these patients with so many things, either with steroids or with the platelet supplements or like this. And patient, actually, if the immunity level of the patient is good, they respond of their own with increasing platelets after 6 to 7 days. But here in these patients, if the patient has a COVID, platelet count is low, but it is not low like the patients who has got a dengue fever. In dengue fever, platelet count goes down up to 30, 40,000. But here, the most of the time, in all viral, as in all viral infections, here also the platelet count is less, but it is not that less as like dengue fever. Then fourth important thing which we do in CBC is hemoglobin level. We know that in dengue fever, because I am comparing dengue with COVID, because these are the two diseases most of the times coexist, because I am seeing so many patients of dengue fever nowadays. But to differentiate between dengue and COVID is nowadays very difficult. So if the hemoglobin level, particularly in patients of dengue, we know that there is a hemoconcentration. Why there is hemoconcentration? Because there is a capillary leak. Because of hemoconcentration, hemoglobin levels are a little bit more in patients of dengue rather than in patients of COVID. In COVID patient, most of the times you get hemoglobin levels to be at almost normal levels. They are not less. Or if the infection is severe, they might be, there is a little bit change in hemoglobin. So take home message from this CBC is, if the patient has COVID, eosinophil count you must see, it is very less. Then lymphocyte count, which is also less. Platelet may be less, but not to that extent. And hemoglobin levels are almost normal. This is about the most important investigations which we are doing in day-to-day practice. Then second important investigations which has been advised in patients of COVID is D-dimer test. What is a D-dimer test? It is mainly it indicates the thrombosis. We were doing this D-dimer test in patients of myocardial infarction coming with pulmonary embolism. To find out the level of the pulmonary embolism, we used to do a D-dimer test, and it is an indication of a thrombosis. This is an indication of a thrombosis. We know that in patients of COVID, there is endothelial inflammation. Because of endothelial inflammation, there is a clot formation. There are a lot of clots which has been formed in so many vessels in COVID patients. And these clots, any clot which has been formed in our body, it gets break up. It is the clot lysis, because the D dimer, what happens is the D dimer is elevated if there is more lysis of the clots. So this is a fibrin degradation product. This is one of the fibrin degradation product, which is because after clot is formed, there is a fibrinolysis and there is a fibrin degradation product. This is one of the products of fibrin degradation. So the patient who has got high levels of D dimer, and suppose the patient's D dimer level, there is a single vessel is affected. There is a clot in one vessel. The D dimer level may be suppose 100 or 200. But as the number of vessels are damaged, or there is a clot in the more and more number of vessels, the D dimer levels are very much increased. Suppose the patient has got 100 or 200 D dimer level, and there is a 1000 D dimer level. If the vessels are affected more, that means there are 10 vessels are affected, and there is a clot in 10 vessels, the D dimer will be high. So it will give you the severity of the thrombosis in patients of COVID. So the D dimer is a very important test, which is done in so many cases. Even we are doing in a thromboembolic when the patient is a thromboembolic episode.
Devgavkar sir, excuse me, 5 minutes remaining.
What?
5 minutes remaining, sir.
Only 5 minutes.
Yes, sir.
Okay. What is the significance in treatment of this D dimer? D dimer is useful in patients to give how many days we should give antiplatelet drugs, how many days we should give low molecular heparin in these patients, which is very important, because so many times when a patient comes after 2-3 weeks, D dimer level may be same. So particularly in patients who have got diabetes and underlying diseases, in such type of patients, we have to give antiplatelet or low molecular heparin drugs for more time. So that is the importance of D dimer test. When does it decrease? Actually, when the patient doesn't have any symptoms after 2-3 weeks, so you are not supposed to do D dimer levels. Even if it persists, you should not bother much if patient is asymptomatic, because you may get D dimer levels increasing for so many days. How long do we test this? It is not required to test it again. Then most important thing is C-reactive protein. C-reactive proteins are we know C-reactive protein in all inflammation, they are increased. So what is it? Once the virus enters in your body, it enters in the lymphocytes. And there is when lymphocytes, it attacks lymphocytes. So lymphocytes, there is a storm, lymphocytic storm. And when there is a lymphocytic storm, there is increase in CRP levels. CRP levels are increased very high in that particular conditions. It can be done. It is like so many times we are not able to do interleukin 6 levels. But if you are able to do CRP levels are also sufficient to indicate the cytokine storm in this patient. Because that's why it is important. We know that when the patient has got cytokine storm, and if you treat them immediately, there are chances that patient recovery is very fast. Then how does it affect our treatment? As already I have discussed, is because once the CRP interleukin 6 is increased, we have to treat the patient aggressively with these newer drugs. We know we are treating with them. So nowadays that drug also has come in whether it is to be given or not because of its side effects. This is interleukin 6. If you are not able to do interleukin 6, because if you do interleukin 6 at different labs, you may get different results. But if CRP is done, it is almost it is called as reproducible, because the CRP levels are almost same in almost all the labs. Then another important thing, we are doing serum ferritin in all these patients. The normal level is 200 to 300 nanomolar. All these are inflammatory parameters: serum ferritin, interleukin 6, and CRP levels. This is very important. Then what important thing is RT-PCR test which we are doing. What sample we are taking is either we are taking throat or nasal swab. What is the CT score and what is its importance? We know that RT-PCR is polymerase chain reaction test. So CT score, which is given so many times, it is a CT score. It is not a CT score of the HRCT test. It is a CT score of the RT-PCR test. If the CT score is high, the infection is less. But if the CT score in chest scan is high, that means infection is very high. So it is a serious infection. But if the CT score here in RT-PCR test, if you see, because we are testing 3 antigens in RT-PCR test. Out of these 3 antigens, if the severity of the virus is high, of the infection is very high, this RT-PCR score here is less. Means if the RT-PCR score is 5, the infection is supposed to be high, and if the RT-PCR score is 30 or 25, it is less. You must be seeing, if you see the RT-PCR report, on the right side you can see the CT score. which is very important because so it is very difficult to understand so many times. And when RT-PCR is to be done, it is the 5th day, which is supposed to be the very important after exposure, where you get RT-PCR to be done is positive test. If you do the RT-PCR day on 2nd or 3rd day, there are 30% chances that this test may turn out to be negative. So because 38% fallacy is known in this, so RT-PCR ideally it should be done on 5th day of the infection. Suppose you are getting infected today, you don't get, and suppose I phone you that you have been in contact with me today, and I have phoned you after 2-3 days. मैं तो पॉजिटिव आया तो आप टेस्ट करके लो. But if you do test after 2-3 days, it is of no use. You do your test after 5th day. That is means, suppose I inform you on 3rd day, -3 you should take it. Do we need it at the time of discharge? It is not advisable nowadays. Even ICMR doesn't allow advise. So this is a graph which shows you that after exposure on 5th day, here also you can quantity of RNA sample. Here you can see that on 5th day, there is a maximum chances that this RT-PCR test comes to be positive. And this positivity remains almost for 22 days. And we know that after 12 days, the infectivity goes down. Infectivity, even if he is RT-PCR positive, infectivity of that patient goes down. So even if we do the test after 2 weeks or 3 weeks, it may come out to be positive, but we tell the patient that you need not worry because you are not infective to the society, but you are carrying the infection. But your virus is not that much infective. So ideal time of doing test is 5th day. This graph, this blue color, ideal is 5th to 7th or 8th day. You may get, there are more chances of getting this test to be positive. Because if we know that RTP polymerase chain reaction, it is a rotation. If to detect the virus, if it takes more rotation, that is a CT score. More rotation means the infection is less. Because if suppose on 1st or 2nd rotation only your test come to be positive, that means your viral load is very high. So CT score high means infection is less. CT score low, infection is high.
Excuse me, sir.
Yes,
1 minute remaining.
Yes, just madam. This is about antigen test, which are doing nowadays. It is very common. It is 100% specific and 60% sensitivity. That means if your antigen test is positive, you need not do RT-PCR test. But if the antigen test is negative, you have to do for the RT-PCR test. This is antibody test, which comes to be 28 days. It is a passport for partying or moving across the world if your antibody levels are high. Then chest X-ray, the radiologist will discuss in detail. Then RT-PCR, these are the photographs of the. Then I will just have 2-3 slides. How you are going to correlate clinically and microscopically and pathologically. If the patient has a cough, dyspnea, and chest X-ray show features of pneumonia, CT, ground glass opacity, microscopically it shows pulmonary edema, consolidation, pleural inflammation, pleural and bronchopneumonia, and clinically it shows that there is a direct viral infection of the pneumocytes. There is a high, you may get high cytokine storm, chances of getting cytostorms are high. Relatively, there are more incidents of thromboembolism. So this is the cardiovascular system. It also gets affected. Here also hypertension, coronary artery disease. If the patient has got, there are more chances that these patients have got an incidence of more thromboembolic episode. So these and microscopically or pathologically, you can see the changes of pre-existing cardiac diseases, including myocardial hypertrophy or coronary artery disease. So this is about the these biomarkers which are increased if the patient has got cardiac involvement. And then this is a thromboembolic episode. Just if the infection is severe, the chances of getting thromboembolic episodes are high. This is about the patients infection to the GIT also. Patient has got diarrhea. In such patients, raised LFT levels, liver may show shock, necrosis. This is the pathological features which has been, and there is a direct viral infection of the gastrointestinal tract. This is about the renal involvement. There may be acute kidney injury because of severe infection of the virus. Acute tubular injury can be seen. Then evidence of pre-existing comorbid conditions will be seen, and patient may go for a shock. That is a clinicopathological. Thank you. Thank you very much.
Thank you, Devgaonkar sir. Very elaborate presentation. And I guess the take-home message was not just clinically, look at the labs and decide about the next course of action. Just one word about RDW, sir. Maybe just a line about RDW from your side.
What?
Red cell differential width in COVID. there's this new study coming about RTW is increasing cases of bad COVID cases. So any
Okay.
comments on that, sir?
I have not gone through it, madam.
I guess we are already beyond the time, so.
I have gone through the literature on eosinophils, which is very important one.
Yeah, that was interesting. Actually, one interesting observation which most of us must have missed. So,
Yes,
yeah,
yes.
thank you, sir. Very interesting talk. Now I hand over the talk to the next speaker. Thank you so much. Bhavik can take over.
Yes, ma'am. So for the next talk, we have Dr. Dirish Rajataksha. So we'll be talking about the COVID-19, the urban context. For this, I would like to call upon Dr. Surendra R. Jaiswal. He's a senior consultant physician in Aurangabad. He's the president-elect of MAP, ex-president Physician Association of Aurangabad 2016 and 17, and organizing chairman of MAP. Surendra sir, on to you, please. Surendra sir?
Hello.
Yes, well, sir. Yeah.
Can I, whether I am audible?
Yeah, you're audible, sir. Please proceed.
Dr. Rajataksha is going to talk over the urban patient, how they are dealing. Dr. Rajataksha is at present he is president of eMAPCON, and he is working at Nayar Hospital, Mumbai, and he is handling a lot of patients who are there, and he is head of the Department of Medicine at Nayar Hospital. He was president of Maharashtra Association of Physicians. He is president. Now I will hand over this mic to Dr. Rajataksha. Dr. Rajataksha, sir, please. Hello.
Rajataksha, sir.
Can you 1 minute? Can you hear me?
Yes, sir, we can hear.
Oh, yes, oh, yes.
Okay. There's some problem. I'm not visible. You can see my screen?
Yes.
Yes, sir.
Yes, sir.
You'll have to go to share screen and make it on full screen, slide share and start. Rajataksha, sir.
The screen sharing is paused. That the thing is coming. Your screen sharing is paused.
Bhavik, can
I'm not able to see.
Yeah, sir, it's on from here. Actually, we can see your screen as well. But from
I
our
can see.
end, so from our end, the screen sharing is on, sir.
Okay, I will start. Okay. So as far as the COVID-19 journey of our Nayar Hospital is concerned, it all started in the month of March. In the month of March, we were celebrating Holi. And just before that, many of us have met in Pune for the diabetes conference. And that time we were discussing a little bit about this particular COVID infection and COVID pandemic, which we're hearing from China and some few countries in the Europe. whether it will come to India. Some people were saying, no, it will not come to India. Just some flu and all. But then what happened? We went back and there was Holi immediately after that, next day. And within 2 days of the Holi, we had one particular patient who came to us. And this particular patient was a 29-year-old male. And he was a known case of chronic kidney disease on hemodialysis. And he was having hepatitis B positive status as well. He had a recent history of travel to Bihar by flight. And he had come back just 7-8 days back. And he had started getting fever and cough with some expectoration. And his diagnosis was lower respiratory tract infection with CKD with hepatitis B positive status. With this particular background, actually, I had attended some other conference because we had some hematology conference. And my registrar who was there, she thought that this particular patient could be, nobody was thinking of COVID during those days. This patient could be of COVID, and she sent the swab. It was not easy to send swab that time. You had to get the swab from the swab material from Kasturba Hospital, and then she sent somehow it to that particular place. And then everybody was worried. How can you send swab? This patient cannot be of COVID. And meanwhile, the patient got so much of panic that without waiting for that particular report, he just went against medical advice. So that was our first thing. But later when we thought that this particular patient, who's a case of lower respiratory tract infection and had a history of travel by flight from another state, whether this could be a case of this thing, COVID. So that was our first encounter. And then, within next few days, we started getting positive cases of COVID in our hospital. Then what happened is, on 19th of April, it was decided, or 18th of April rather, it was decided that Nair Hospital would be the first hospital or first medical college in the country to be declared as dedicated COVID hospital. So we'll see 100% COVID patients only. So entire hospital was made into a COVID hospital, so dedicated COVID hospital. And then we could see largest number of critical and severe COVID patients over last 6 months. This is another case which came in the month of April, and he was a 50-year-old male. He was an Uber driver without any comorbidities. And he presented with fever, cough, and breathlessness for 4 to 5 days. His saturation was 88%, but with bag and mask ventilation, with oxygen of about 8 to 10 liters per minute, he was maintaining 88. But his chest X-ray, when we saw, was showing bilateral fluffy shadows. Okay, so we made the diagnosis of LRTI with ARDS. His RT-PCR tests came positive. And then this patient on day 9th became very bad, and his all the lungs were having full of various the shadows, and his oxygen saturation started dropping. And then we had to shift him on BiPAP ventilation, and he remained there for almost 20 days on that particular non-invasive ventilator, and luckily he came out and went home. So this was a patient who was very bad, and ultimately he went home nicely. Then in the month of May, if you see, this is very interesting case. I think Dr. Devgaonkar sir just mentioned about similar symptoms. Now this was a 63-year-old male. He was extremely obese. His weight was 125 kilogram, and his history of diabetes and hypertension for more than 15 years was there. He was a known case of acute anterior wall myocardial infarction 5 years back and had undergone CABG 4 years back. Now this fellow came with fever and sore throat for 5 days. But then what happened, just 2 days prior to admission, he lost his taste and smell. Now this particular symptom, as Dr. Devgaonkar sir correctly said, we are finding, something, it is not uncommon, it's not very rare, but it is, we are seeing for the first time in this particular type of patients. His RT-PCR was positive, and we thought So the most risky thing is not diabetes, it is not hypertension also, it is not ISD also. According to me, the worst thing is morbid obesity. As far as the mortality rate is concerned, what we have seen in 10,000 patients, the worst mortality has come with morbid obesity. Somebody is having BMI about 33 or 34. Now this patient was fitting into that, and we thought that this particular patient is going to worsen. So we observed him for 17 or 18 days. But surprisingly, at that time for us, this patient never required even 2 liters of oxygen. His oxygen saturation on room wear was always normal. And then we started more and more number of patients with this symptom, that is loss of smell and loss of taste. And then we realized that loss of taste and loss of smell are good signs. In the sense, if you are going to get COVID, then these are good signs, because with these signs, if the patient comes to you, most often or most probably they are not going to worsen into ARDS and they are not going to die. So this particular patient taught us one lesson, that this particular patient with this particular symptoms survived and went home walking. This is another interesting case, one mother and son, and both were having multiple comorbidities. This lady was about 84-year-old and her son was about 62-year-old. Now both of them, they got admitted in the month of June in our ward. Both of them were having comorbidities of hypertension and diabetes. When they came, their oxygen requirement was less and they were given all possible treatment. But in spite of that, both of them worsened and they required BiPAP ventilation, requiring large quantity of oxygen. So they worsened for almost 2 weeks, and slowly, they started recovering. So it was to the surprise to us that in spite of having age more than 80 and having multiple comorbidities, uncontrolled hypertension and uncontrolled diabetes, these two patients, they recovered very well, and both of them went home walking. Not only that, the son with his another brother, both of them came to us after 15 days of discharge, and they gave donation to our Department of Medicine in the form of check. Remember, they are not very rich people. They are living in some chawl, okay? But in spite of that, they felt that gratitude, and therefore they decided to give some amount to our Department Development Foundation. And this is in our Dean's office. They handed over to our Dean, and this particular thing came in the newspapers as well. So in fact, if you see, we saw a lot of patients. If you see from the March to the October, about 17th or 18th of October, I have the data. We have seen about 10,000 patients, and almost all such patients, if you see, were requiring oxygen. So that was a great experience for us. If you see, no hospital is built in such a way that each and every patient will require oxygen, and not only that, each and every patient will require more than 8 to 10 liters of oxygen. In fact, some patients will require 40 to 50 liters of oxygen per minute. So such type of oxygen need, none of us has seen in, suppose I'm say practicing as lecturer and then professor for 32 years in a municipal setup and seen thousands of such patients, but I have never seen a situation that almost all patients are requiring such a high quantity of oxygen in my 32 years of practice. So if you see, the patients went on increasing till the month of June and July, and after that, if you see, in the month of August, as we had predicted, by 15th August, if everybody follows the rules, wears the mask, social distancing, etc., the thing will come down. But you see, during that month of August, when it was coming down and we were expecting, even the commissioner sir had declared that the pandemic is over as far as Mumbai is concerned. But then we had various festivals in the month of August of various religions, and during that, nobody followed this particular social distancing and mask and all. And then what happened? At the end of August, the number of patients started rising, and again in September, we got large number of patients. But if you see, in spite of that, the number of deaths were going down. So what we have learned, that if you come in the month of April and May, the chances of deaths were high. But
Dr. Rajadaksha, 5 minutes more.
How many?
5 minutes.
5 minutes. Okay, then I will do in 5 minutes. Don't worry. So what I'm trying to say is the experience, all the physicians, remember in the month of February and March, none of us were knowing what is COVID, and none of us, even if you're a professor or if you're a junior resident, nobody knew what is COVID and how to manage COVID. But with the experience of seeing a large number of patients, some experience we got. Even today we know there is no cure for COVID. The patient who is going to die is going to die. But if you see the mortality in the month of May, only 22 patients and 3 patients died. So it was only 13. But then mortality started increasing as the number of critical patients increased. And again, if you see, it has started coming down from the month of August. Now now in October, till this is 17th or 18th of October, our mortality has come down to 8%. Okay, so this is with experience. All the physicians learn. We all learn by our mistakes and all learn by our experience. So that is how the mortality has come down. Okay, I will not go into that. So this is the same Venn diagram which is showing how different type of patients were coming in the different age group. But remember, the mortality was highest, I want to say, with this diagram above the age of 60 or above the age of 55. Maximum people had died or above the age of 55, and maximum patients who died within first 48 hours. That means they came to our hospital after staying in some other place or remaining at home only, and therefore when they come, they were in such a worse condition that they died within 48 hours before we could do anything. I think lab investigations, Dr. Devgaonkar has elaborated detail, but interleukin-6 is a very important investigation, and when the interleukin-6 starts rising, this is the time of the cytokine storm. And cytokine storm, if you catch these patients at this stage, cytokine storm, if you catch these patients at this particular stage, remember, and you give monoclonal antibody like tocilizumab or itolizumab, then only during that particular period it works very well. But when it works very well, you have to remember that procalcitonin D-dimer, sir has said very categorically. And for D-dimer, remember, I must thank Italian pathologists. When the whole world was denying autopsy in the patients of COVID, Italian pathologists did autopsy, and they found out the role of hypercoagulability in the pathogenesis of the ERDS. And therefore, it was decided that you will give low molecular weight heparin or heparin to these patients, and that is how they saved many lives. This is the cytokine storm which I wanted to say. But with the cytokine storm, if you give these monoclonal antibodies, remember, neutrophil lymphocyte ratio is going to go haywire in some patients, especially if they are older patients, especially if they are diabetic patients. And there, if you don't say, what will happen is their oxygen requirement may come down, but they will go into sepsis. This has happened to at least 3 of our patients who improved as far as their lung conditions were concerned, but then they developed sepsis and they died. So I want to say that this particular tocilizumab and itolizumab are double-edged swords, and we have to handle very carefully. And the neutrophil lymphocyte ratio is going haywire. You have to go to higher antibiotic, maybe from augmentin to piperacillin tazobactam, from there to meropenem, something like that. So management, I think everybody is saying, but whole hallmark is oxygen therapy. You can give with nasal prongs. There are various advantages, but there are disadvantages. You cannot give more oxygen by nasal prongs. Then you can give non-wheezing unit, that is bag and mask, what we say, up to 10 to 15 liters you can give with this. High flow nasal cannula you can use. And I don't want to show this. And non-invasive
1 minute more, sir.
BiPAP you can give. And lastly, you can give by invasive ventilation. So these are the various ways. I think we are all running short of time. Dr. Jaiswal is worried that our time is getting over. But I think there are a lot of things which can be said about our experience with this thing. With such a short time, it is not possible for me to cover. At the end, see what another short thing, 1 minute, I want to show you that if you do it in a prone position, the ventilation, if you can give in the prone position, even I'm talking about very bad patients who are requiring large quantity of oxygen. If you do at least 2 hours prone ventilation, then the chances of coming out. And one of our doctor friends who is 60 plus age, and he was extremely bad, and the doctors had given up the hope, but he said, I will do this prone positioning. And with this prone positioning, he came out after 32 days spending in ICU. So what I want to say is that this is one thing which we have learned in the month of April and May, that prone ventilation, you can bring out these particular patients. Before I end, I want to see the various X-rays and CT scans which I had, which I don't want to see. All of you must have seen this. But this is the way These our ladies and our boys in the Department of Medicine and other departments who supported us have worked to conquer corona pandemic. Still we are not conquered, but we are fighting very well, and ultimately we'll say hum honge kamyab. We all will win if we remain united, we remain focused, we follow social distancing, we wear masks, and we take all the precautions. I would like to thank my colleagues who have helped me in preparing this particular presentation, because I was extremely busy. I couldn't have done it without help of these three people. So I want to thank you all for patient listening. Thank you.
Thank you very much, sir. Rajesh sir, you have elaborated in a very beautiful manner, and you have treated so many patients at Nayar Hospital. Sir, everybody is appreciating you.
Thank you.
I will ask only one question.
Yes, sir.
The mortality rate in Mumbai and Pune is higher as compared to the rest of Maharashtra. Can you tell me the reason?
I will tell you that the Pune is not really very high, but Mumbai definitely. Our rate of mortality rate of Mumbai city was more than 6%, and now if you see, it has come down to 4.05%, so less than 4.1%, close to 4%, and it is decreasing every day. Now the thing is, Mumbai started getting the cases in the beginning, so we started getting the patients in the month of March. That is number one, because the experience was less. That's why more, the management was not, there was no protocol set. Actually, I couldn't elaborate on that. So whatever protocol, we get lopinavir, ritonavir, hydroxychloroquine, azithromycin, whatever. Some people have given oseltamivir also, but there was no clear-cut idea how to treat this particular patient. Nobody knew. So that is one reason. And various other oxygen delivering systems like HFNCs and BiPAPs were not available in that big quantity. So that is the reason. And we get patients from all across the state who are bad. So that is another reason that we lost the patients.
Thank you very much, sir. Now over to Rajadesh, over to Amit, sir.
Thank you, Jaiswal sir. Thank you, Rajadesh sir. Bhavik, can you take it forward, please?
Amit, एक प्रश्न विचारू का?
Sir. Hello.
Can I ask one question to Rajadesh sir?
Oh, sir.
Huh?
Oh, sir.
Sir, Rajadesh sir, you are there?
बोला.
Sir, आता रेमडेसिवीर बद्दल सुद्धा controversy चालू आहे.
हो.
Nowadays, but
Yes.
in my opinion, or in my practical, the way I am doing a practice since last 3-4 months for COVID, the remdesivir plays a very important role in recovery. What is your opinion?
Yes, actually, I would like to say that there was a meeting with Central Health Department Secretary, and I was with our Dean sir. Actually, didn't discuss, but it was likely that they will discuss about remdesivir. And I was there to say that remdesivir works. Even tocilizumab also works. Remember, even tocilizumab, though Roche has said it doesn't work, but it works if you give in the selected period. So remdesivir will work if you give to these patients during first 3 to 4 days of becoming positive. But if you give very late, you give after 10-15 days when the patient is already in full-blown ARDS, it is not going to work. So timing of all these drugs is extremely important, and that we have learned over a period of time with experience. So like that, what you are saying is absolutely right. And we feel that all the physicians, especially MAP, should strongly support use of remdesivir till we get a good vaccine or till we get a curative drug like oseltamivir is there for swine flu. Similarly, till the time we get a curative drug for this particular condition, remdesivir and favipiravir we have to support. But remdesivir definitely has worked well.
Thank you, Rajesh sir. Bhavik, can you take it forward, please?
Yes, sir. So for the next session, we have Dr. Bhavin Tankaria, who will be talking about interpreting HRCT thorax in a COVID-19 patient. For this, I would like to welcome Dr. Anjali Rajadeksha. She's a consultant rheumatologist at Alliance Hospital, Mumbai, head of unit KM Hospital, Mumbai, and joint secretary of MAP.
We cannot see Dr. Anjali Rajadeksha, the screen.
She is with Girish sir itself. So
okay.
No, she's not with me. She is not with me. She's there. She's in a different place.
I have logged in. You can show.
Oh, okay.
Logged in with a different device.
Okay, great. Yes, ma'am. You can please go ahead.
Yeah. Hello. Am I audible?
Yes, ma'am. We can hear you.
Yeah. For the next session, We have Dr. Bhavin Jankaria, who is a senior consultant radiologist of Jankaria Imaging Center, Mumbai, and editor-in-chief of Picture This magazine. He will be speaking on interpreting HRCT thorax in a COVID-19 patient. The dreadful complication of COVID-19 is infection, lung involvement, and in early stages, X-ray may not show or will not pick up the findings, and hence HRCT chest becomes a very important tool to diagnose the lung affection in COVID in early stages. So we have Dr. Bhavin Jankaria, who will enlighten us more about the HRCT picture in COVID-19 patients. Over to Dr. Jankaria.
Thanks, Anjali. And just to let you know that Anjali and I are batchmates, and Girish has been my teacher and senior. It was lovely listening to him. I just sometimes wish we could publish all this data instead of relying on data from China, Italy, US,
Yes,
UK,
yes, yes,
etc.
Bhavin. Yeah.
At some point, we should have all that down. Anyway, so let's move on to my talk, and I'm basically going to spend about 15 minutes talking about how what are the things we see on a CT chest in COVID-19 patients, and what are the questions that we still need to answer. So I'll break this up into the CT signs, differentials, diagnostic classification systems, severity scores, and short and medium term follow-up, and the so-called fibrosis. The signs, most of us know them well. We see ground glass, which is increased opacity that does not obscure the underlying vessels. And most of the times this is perivascular. And I'll come back to why this is important. If the ground glass is associated with these areas of septal thickening, we use the term crazy paving. And you can have consolidation in the center and ground glass at the periphery. This is just a halo sign, and the consolidation is recognized when you see increased density that obscures the vessels, but you see these air bronchulograms within. And then a lot of people talk about this reverse ground glass appearance, where you have ground glass in the center and consolidation at the periphery. This is not necessarily pathognomonic of COVID, but in the correct clinical setting, it is. So just to put those two together, here is the ground glass in the center and consolidation at the periphery. And here is your standard consolidation in the center and ground glass at the periphery. And often we get these mixed appearances where you have some consolidation, some ground glass, almost looks like a feather here. And these are patterns that we see in COVID patients. Consolidation, we've already discussed, but when it occurs on its own like this often has the so-called organizing pneumonia pattern. And multiple patients here who have either subpleural bands as part of the organizing pneumonia pattern, or these are peribronchovascular, or a mixture of both. And this is also typical of COVID-19. We also get reticular opacities like we see here, where you just get these strands of abnormal shadows, usually associated with some ground glass that we see here. And this also is seen in COVID-19 patients, often looks like an NSIP pattern. And we already talked about this septal thickening, which is also a type of reticular opacity. We also see bands. We can see thin bands or thick bands. For quite some time, we didn't know what they were, but now using dual energy perfusion CT, we kind of know that this is edematous lung, and what you see here as normal lung is actually hypoperfused lung, which shows up as perfusion defects on dual energy CT, and I'll show an example of that. The severe patients that get admitted in hospitals, require ventilation, etc., then have this appearance where you have significant involvement of the lungs, as you see here. Often they have sparing of the anterior parts of the non-dependent areas, and these are often also hypoperfused, and so there is a perfusion defect here. And this is a pattern that people are familiar with as well. What we do need to realize is that none of the patterns that I have described are necessarily classic for COVID-19. They are seen in other conditions that I have listed here on the right. And obviously in the correct clinical setting in the last 6 months, we would assume these to be COVID, but we must be careful that we don't miss out on non-COVID conditions as well. So prior to COVID, for about 20 years, we've been diagnosing these cryptogenic organizing pneumonias or organizing pneumonias that occur following chemotherapy or following or within rheumatologic conditions. You can have pre-existing interstitial lung diseases, which could be mistaken for COVID, and these could have this acute exacerbation with ground glass that is mistaken for COVID. Chemotherapy lung injury on our PET CTs, even today, we're having trouble differentiating that from COVID. Secondary alveolar proteinosis, this was a patient on sirolimus post-renal transplant. Your ANCA positive GPAs and other vasculitic conditions can also be a problem, and so can IgG for disease. Obviously, once you have the clinical background, these are less of a problem, but for radiologists often, there is a chance of making a mistake. However, one set of signs that separates COVID-19 from others is those that you get with angiopathy and vasculopathy. So here are these very subtle early signs of patients who are usually asymptomatic. These occur because of endothelitis, and these are perivascular areas of ground glass. And you can see the vessel in the center and ground glass at the periphery, which is essentially an interstitial edema. In more pronounced cases, we see dilated vessels either proximally or in the center. And we often see this vascular tree and bud as well. So you have this central vessel, and then you have these budding vessels coming out, and these are due to microthrombi. When they occur in admitted patients, so you can see the vascular tree and bud here or here, then they come with a slightly worse prognosis. We don't normally see vessels going up to the periphery. So when we see vessels in the last half centimeter of the lung, that is part of the vasculopathy as well. And the classic sign of a vasculopathy is this target appearance where we see the vessel in the center, the perivascular edema, relatively spared hypoperfused lung, and then you have the larger ill-defined area of so-called consolidation or compressed lung, which gives us this appearance. And if this part is sharp, we call it the double halo sign. We now do dual energy in some patients where it's possible. So this is a CT pulmonary angiogram, wherein we can also look at the perfusion. So that's showing us the perfusion defect where we have this area of abnormality. But you also see this hyperemia. You see the yellow areas which show that there is increased blood flow at the periphery of the perfusion defect. And then you see the perfusion defect here, telling us that these are all related to the presence of microthrombosis. Remember, see that the proximal vessels are not thrombosed, right? You see perfusion defects and hyperemia because it's at a microscopic level. However, you can see it at a macroscopic level. So here we have a target sign, and you actually have filling defects here on both sides telling us that there's thrombosis. We don't use the word thromboembolism because this is de novo thrombosis because of injury to the vessels that occurs. And so we need to understand the etiology. So these are all the signs of the pulmonary angiopathy on plain scan. And these are the 3 signs on a contrast study. So let's move on to classification systems. And everybody writes CORADs in their report. So we need to know what these are. These are only to show how confident the radiologist is to say that this is COVID-19. So if I say it's CORADs 5, that means I'm confident this is COVID-19. If I say it's CORADs 2, then I'm confident it is not. So this is a CORADs 1, typically normal. This is CORADs 2 in tuberculosis. So we know it's not COVID. CORADs 3 is where I'm not sure. I'm seeing some ground glass, but it could be, may not be. Here I see this classic perivascular ground glass. So I'm almost sure this is COVID, and this is classic. This is also unilateral disease, but I'm almost sure it's COVID, and this is classic COVID. So when we say 4 and 5, we're almost sure it's COVID. When we say 1, 2, 3, with 1 and 2, we know it's not COVID. With 3, we're not sure. And there have been some validation studies that have shown that the sensitivity and specificity of saying that something is CORADs 5 is very good in symptomatic patients, but the sensitivity is not very good in asymptomatic patients. the other system used in the Western world is the RSNA expert consensus statement, which is actually simpler and makes more sense. It just divides it into typical, indeterminate, atypical, and negative. So that's negative, which is a good word to use. This is atypical. We would say that it's suggestive of TB. This is indeterminate. I would say I'm not very sure. This is typical and this is typical. So somehow CORADs became viral in our country, and that's not a good analogy to use. So everybody uses CORADs, but frankly, I would prefer to just say whether it's negative or typical or atypical, and I still use this in my reports along with the CORADs. So again, validated, and they've shown that if you say it's typical, then it's a high positive predictive value, etc. The other thing we see in our reports are severity scores. And these severity scores are of many types. Some people use out of 45, some out of 20, but the standard one that PAN, etc. came out with earlier on, this was actually an online paper in February, is the out of 25. And so basically you divide into 5 lungs, right upper, right middle, right lower.
So Bhavin, you have 5 more minutes.
Right, including lingula and the left lower lobe. And when you see, you basically visualize this on axial, coronal, and sagittal, and then score it based upon how much of the lung is involved. It's all visual. And typically a score greater than 18 predicts a worse outcome. But this is for the physicians to use. There are other complicated systems. There's quantitative analysis. In this patient, for example, semi-quantitative is greater than 18, and we have other systems that use artificial intelligence, as in this patient, telling us that there is 21% or 22% lung involvement, which would imply that there is significant involvement. So bottom line is more the lung involved versus the prognosis. Lastly, follow-up. We know that most patients who have disease will resolve. We use terms like melted sugar, like you see here, or cotton candy or tinted sign. But some worsen, and most of these are usually due to the underlying angiopathy, or they get an ARDS phenomenon. This patient was actually doing well and then worsened. Some patients, this is 11th August, 20th August, are improving, but they've also developed some new lesions, which probably happens in the interim if you scan to close to date. So I guess that shouldn't be happening. Then we have medium-term sequelae. This was a 46-year-old, 1 month in the hospital. This was 16th May, and then June things worsened. In June, we would have then said, oh, this looks like fibrosis because there's so much disease, shrinkage of lung. But by July, the lesions have started improving. And in August, they've actually improved a little more. So there is some fibrosis. There is traction bronchiectasis, but the lesions are improving and the patient is improving. So we still don't know exactly what's going on. Here's a 47-year-old lady positive in June. There was nothing here except this peripheral disease. And now you see traction bronchiectasis in July. This looks like fibrosis, and yet in September, some of this has improved, some has remained. So my point is, we don't know what's happening with post-COVID ILD. I don't like to use the term fibrosis because we don't know whether this is truly fibrosis. See, fibrosis should not be improving ever. It would be only non-fibrotic lesions that improve. Perhaps they look like fibrosis, but there are not. So we need to wait. As we have more follow-up, we will learn more, and that's when we will be able to say what exactly is going on with these lungs. So this is all new learning for us that's happening. So what I've done in the last about 13, 14 minutes is we've looked at different signs like ground glass consolidation, bands, and then looked at the signs of angiopathy and vasculopathy, the differentials of all these signs, classification systems like CORADS, and the more sensible RSNA system, but unfortunately CORADS is the one that we're using in India. Severity scores, many people use different scores, but the one used by the majority is the 1 out of 25. It's a visual analog scoring system. And we also have
Bhavin, 1 more minute.
systems. I'm on my last slide, Anjali.
Yeah, sure.
Yeah,
I'm just reminding.
No, but the interruption also creates more time loss.
Yes, sure.
Yeah. So, And then this is the short and medium term follow-up. And I've shown some examples and my problem with the use of the term fibrosis. This is the book I wrote last year. It doesn't have COVID, obviously, but we will have a second edition. It's available on Amazon for anyone who wants to buy it. And thank you so much for inviting me here. It's been a pleasure. I've been a part of MAPCON many times physically. And I wish everyone all the best and hope everyone is safe and sound. Over to you, Anjali.
Thank you, Bhavin. There is one question. How early we can get ground glass changes in an HRCT?
So typically we've seen it within 4 or 5 days of the patient being symptomatic. But we've had asymptomatic patients walking in who were RT-PCR positive, let's say today, and we see subtle changes. The ones that I showed, the subtle perivascular ground glass. So I'm assuming that if you were infected today, probably within 4 or 5 days, you would see it, and even if you were asymptomatic, we see subtle lesions if we look for them.
Yeah. Okay. Thank you so much, Dr. Bhavin. Hand over to Dr. Amitar.
Thank you. Bhavin sir, just a small comment. It's a wonderful plaque here at the back. Friends and the families you choose.
Sorry?
It's a wonderful plaque you have at the background. Friends and the family you choose. It's a beautiful statement. Thank you so much, sir. It was a pleasure to listen to you.
Thank you. Okay.
Thank you, sir.
Thanks.
Over to you.
Is it okay if I leave?
Yes, sir. Yes. Thank you so much for the time.
Thank you. Yeah. Bye, Girish, Anjali, and everybody else.
Bye. Thank you, Bhavin.
Bye.
So on to the next talk, we have Dr. Shiv Kumar Uttare, who will be talking about teleconsultation, medical legal do's and don'ts. For this, I would like to call Dr. Amit Saraf. He's an MD from FRCP London, Edinburgh, Glasgow, FSCP Philadelphia, FCPS, Director Department of Internal Medicine, Jupiter Hospital, MRCP London Examiner, DNB Teacher and MDA Examiner, and National API Governing Council member. On to you, sir.
Thank you, Bhavik. I take this opportunity of introducing the only surgeon in the entire forum here, but I should add the only famous and the only well-known surgeon in the physician fraternity. Sir has been a prolific speaker. I have heard him from years together, and he speaks wonderfully. In fact, sir was telling me, what will I speak on a physician forum? And I was telling him that, sir, whatever you address us, any topic would obviously be of relevance to us. So Dr. Shiv Kumar Uttare is the president of the Maharashtra Medical Council. He is the member of the National Medical Council as well. He is a member of the Medical Advisory Council, professor of surgery from Grand Medical College, Mumbai, CWC and NWG member of the IMA headquarters, past president of the IMA Mumbai. He is also a consulting surgeon at Fortis Hospital, Shushrush Hospital in Mumbai. And sir will be talking to all of us on an extremely important and relevant topic, the telemedicine's do's and don'ts, and basically the medical legal implications of the same. So over to Dr. Uttare, please. And thank you so much for gracing this occasion, sir. So you have to unmute yourself.
Yeah, thank you, Dr. Saraf, for that introduction. And I think I must thank the whole team of MAPCON, especially my close friend, Dr. Saraf, and of course, Dr. Rajadaksha, a very close colleague, for having called me over here today. So I think the time is short, so I will directly go to the talk as such. And I think COVID challenge for me is to finish this talk within 15 minutes, because this is a huge topic which is there and which I think many of us do not know what exactly we are supposed to do. So basically what during this COVID times, there is one good thing that has happened. And, I always like to see the silver lining in any dark cloud. And one of the best things that could happen was that the Board of Governors went ahead and they notified these telemedicine practice guidelines. Because up till now, telemedicine was not supposed to be legal in India. And we were not even allowed to do telephonic consultation. As you know, there were some famous cases where on the telephone the Supreme Court has held them guilty because they have given some advice on the telephone. But today, because of the COVID problem, the telemedicine, which was there lying in the cold storage for the last almost 3 years with the MCI, they suddenly brought it out. And that is what, because this is going to be not only during the COVID period, but this is going to be a future practice as far as telemedicine is concerned and clinical practice is concerned. So what basically you require to know is, what is telemedicine? Telemedicine is nothing but it is the same thing that we are doing in our day-to-day practice, where we physically see the patient. We are seeing this patient online, so at a distance. And there are a great advantages, not only for us also, but for the patients also, because the patients can connect with their doctors wherever they are. Any part of India they are moving about, they can connect with their doctors, and that connection can be also 24/7 if there are young doctors who are willing to do telemedicine round the clock. So it is a great comfort and assurance to the patients, especially during these trying times of COVID. The advantages are not only to the patients, but the advantages for the doctor also, because it saves a lot of his time. And especially the follow-up patients can be easily seen by the physician. And of course, the bottom line is that even you can keep on earning your, because it has become legal now, your earnings also can increase because of telemedicine. Then cost bearers also, it is an advantage. When we say cost bearers, it's either reimbursement by the company, by the banks, or by the insurance companies, because definitely the costs are going to go down because of telemedicine in the future. So it's a win-win situation for the patients, for the physicians, and of course for the cost bearers also. So basically what you have to understand is, that when I talk to many of my colleagues, majority of them say, today I have started doing telemedicine and majority of my patients are on telemedicine. Then one question I ask them, and they feel very proud that they are, doing telecommunication with their patients. I ask them, have you gone through whatever has been put up by the MCI of what are the do's and don'ts whenever you practice telemedicine? And let me tell you, almost 90% of them say no, they have not. So this is the sad part, because we do not know what are the rules and regulations governing us. Tomorrow you may be in a problem when you are, practicing telemedicine. So please go on the website of MCA. The telemedicine details are there over there. In details, everything is given. I will just rush through all these things. And what basically they have given is the protocols that physician and patient relationship is there as far as telemedicine is concerned. The negligence part, liability, the treatment, how you keep the records, the privacy aspect, everything is given in details. One thing you have to understand as far as telemedicine is concerned, that you cannot do any surgical or any invasive procedure. Nowadays, even physicians are doing a lot of invasive procedures. So under no circumstances you can do that. And not only that you are not allowed to do telemedicine for any patient who is outside the jurisdiction of India. Our patients move about, suppose today, tomorrow they leave India and they go and they try to contact you and then take your advice as far as telemedicine is concerned. Remember, you are not allowed, as of today, you are not allowed to do it as per the rules and regulations. Then there are some of the points that you must know and you must go through. These are the very relevant points of how you are supposed to do telemedicine. So as I said, you can do it for any part of India. Today, what up till now, what we were doing, only the patients who are coming to us physically, we used to able to examine them. But today, if you're sitting in Mumbai and one of your patients, say, has gone to, say, Calcutta, or he has gone to Delhi, definitely you can continue seeing this patient and the patient can take your advice from any part of India. But there are some ethical norms and standards which are application to the traditional in-person care, which is also applicable as far as your telemedicine is concerned. Today, as of today, you are allowed to immediately do telemedicine. But remember, there are some rules and regulations and some mandatory online courses which are going to be notified by the new National Medical Commission, which is already formed. And once that comes into place, within 3 years, you are supposed to pass this mandatory online course. and only then you will be able to continue doing telemedicine. So those who are doing telemedicine now and they have got used to telemedicine, remember that in future after 3 years you will not be allowed to do the telemedicine unless you have undergone this mandatory online course. Then what are the telemedicine applications which are there? You should understand what are they. The mode of communication, it can be either video, audio, or it can be text based. The timing of information transmitted can be either real time, or you can send a text or audio to the patient. Purpose of consultation is also important. Means, is it an emergency consult, then what you are supposed to do? And if it is a non-emergency consult, is it the first consult or a follow-up consult? That is also extremely important. Then of course, this is something that people don't understand, is that not only patients to RMP is allowed, because that is a standard thing that we think about whenever we talk about doctor patient, but even a caregiver to an RMP is allowed as far as telemedicine is concerned. That means suppose there is someone looking after the patient in the house, that person can take your advice on behalf of the patient. RMP to RMP is allowed. That means in a remote place, if there is some family physician and he wants to take some advice of some consultant in some big city or town. Remember now today, as up till now, he used to send the patient to the city, with a referral note, but now he can do telemedicine with the patient sitting beside him. And then of course, health worker to the RMP, that means it could be a nursing staff or whatever it is. They can also, as far as the new rules are concerned, they can also do teleconsultations with you. Now, you have to understand whenever you're doing, this is the commonest, that is a video, there are two types of teleconsultations, and the rules and regulations as far as prescription any drugs is given is that if there is a non-video consultation, then if there is no prior personal consultation, then there are some medicines which you can give. These are the OTC medicines only, but the other medicines which I am not going to go into the details, this is there online, you can go afterwards. So if you have seen the patient before, what are the medications you can give? And if you have not seen the patient before, what are the list of medicines? These are in the list O, list B, and this is all in the appendix 5, which is there. You can go into the details of that, because today don't think that any and all medicine, just like how you do physical consultation, you can do as far as teleconsultation is concerned. There are some rules and regulations, and there are some drugs which definitely you cannot prescribe if you are doing telemedicines. Then again, when you do video consultations also, there is a little more of these list which is allowed for you to do. But again, it is divided into no prior in-person consultation or prior consultation. So again, these are few of the drugs which you are allowed to give, and some of them definitely you are not allowed to give. As far as the old notification is concerned, they were not allowing you to give psychiatric drugs, but then a new notification has come where the psychiatric drugs are allowed to be given. So don't go by this last line. This is the old one where psychotropic and narcotic drugs you could not prescribe, but today they have allowed you to prescribe. So basically, there are 7 elements you have to understand whenever you're going for this telemedicine. One thing is the context. That means that you have to exercise your professional judgment if it is possible for you to give telemedicine or not, or teleconsultation and or not, and should you give a video consultation or audio consultation. That is left to you to decide and for your professional judgment. Identification becomes a very, very important part. Remember, whenever you're doing teleconsultation, you're supposed to identify not only the patient, but your identification should also be given to the patient. That means the first sentence that you say to the patient is whatever you say, good morning, good afternoon, whatever to the patient, and I am Dr. So and so. You are supposed to identify yourself to the patient. And of course, the patient identification, the best part is if you can take the Aadhaar card online of that patient, that would definitely help you as far as patient identification is concerned. Then the consultation should never ever be anonymous, maybe the patient's part or from your part, from both parts. Then the mode of teleconsultation, as I said, it can be video, it can be audio, or it can be text. All the details have been also given online as far as this is concerned. consent forms a very, very important part, where sometimes you feel, why do you require to take consent? So physical, when you're doing examination of a patient, remember, it is an implied consent, that the very fact that the patient has come to you, he implies that he has given you consent to examine him and prescribe medicines. But online, you have to understand, same thing applies, because the patient has initiated the teleconsultation. But if it is a health worker or an RMP or a caregiver, which I have already spoken in the last slide, who are allowed to do teleconsultation with you, then explicit consent of the patient is a must. Only then you can go ahead and do teleconsultation. This is extremely important. Remember, the patient has to consent for an RMP to talk to you, for a caregiver to talk to you about his medical conditions.
Sir, 5 minutes, please.
And far as exchange of information is concerned, so if you feel at any time that the physical examination is a must, you should not proceed with it. Prescription and transmission, the prescription should not be in the word format, which can be manipulated by the patient, and it should be a photocopy or a scan copy or a digital copy only, which cannot be tampered with. And of course, transmitting the prescription, this is for the future, which I am talking about. Today, we are not allowed to transmit prescription directly to the pharmacy. But tomorrow, if you are allowed to do that, as it is being done in the Western countries, remember, here also you require the explicit consent of the patient before you send this prescription directly to the pharmacy. So legal and ethical issues, we will go as far as what is concerned. We have seen what we are supposed to do, but let me tell you what, as far as the duties and responsibilities are concerned. So as per the
2 minutes, please.
Yes, sir. As per the IMC Act, you are not only the IMC, you are supposed to know IT Act and Data Protection Act also, beyond what we are doing now. Then misconduct is there. You should not insist on telemedicine if the patient is saying, no, I do not want to use telemedicine, I want to physically come to you. And at the same time, even the images of the patient should not be definitely used by you. This is there for everybody. And the penalties are as per the IMC Act is concerned. Log records is something, is a must, that you are supposed to maintain the prescription records. Fees, definitely you can charge, but remember, those should be appropriate fees. That means it should not be beyond what you are charging as far as physical examination is concerned. And a receipt should be given online to the patient also. And continue with the telecommunication only if you are satisfied that you have got all the relevant information. And when when RMP to RMP is concerned, there is another medical legal aspect, is who's responsible for anything going wrong. Remember, the primary RMP who's sitting with the patient over there is responsible, because he is supposed to tell you all the details and you only give your advice. So the primary RMP is the important thing. And in emergency situation, can you do telemedicine? Yes, you can do, but it is only for first aid basis, and you have to refer the patient immediately to any casualty or tertiary care. Then guidelines are even there put as far as the technology is concerned. Why you should know this? Remember that if that technology platform has done some wrong and he is blacklisted by MCI or NMC now, remember, under no circumstances you can go onto that platform. So the responsibility is yours to do. As far as the prescription format is given, one format has already been given online. You can see the format, you can make some changes, but this is generally the format which they said is acceptable as far as the prescription format is concerned when you're doing teleconsultation. So in short, exactly what I have told you, all these, the do's and don'ts which are there in this one slide, that you have to identify yourself, you have to see to it that you are satisfied, you can give prescription to that patient. Emergency teleconsultation, but limited to first aid. Personal data of that patient has to be kept with you. If it is given out, you can be tomorrow pulled up by that patient. And limitations on prescription, please go to, I request all of you, please go through the prescription, what you can do and what you cannot do as far as telemedicine is concerned. So thank you very much for having called me here today.
Thank you so much, Uttare sir. I think that was a very, very lucid, and you absolutely in the nick of time have covered a very large and a very relevant topic, especially for us physicians. You're right, sir. I think 90% of us really don't go through the MCI website or the do's and don'ts, and you've tried to concise it in a nutshell for all of us. On the behalf of the entire MAP family, I would thank you for having graced eMAPCON this year, sir. we look forward to you as a faculty at the physical conferences when they hopefully begin from next year onwards. Thank you so much, sir. I think we don't have time for any more questions presently, so we move on.
Only one sentence, Saraf, I would say is,
yes,
please, for God's sake, all of you go through the telemedicine, because tomorrow you cannot say that I was not aware that I was supposed to do this. So ignorance of law will not save you tomorrow, and I don't want our colleagues to be in problem, because majority of the physicians are doing teleconsultation as of now. Thank you very much.
So where this information can we get this telemedicine course?
It is online today. The NMC website is also there. You can go online and see on the NMC website. You will not get MCI now. MCI has already been dissolved.
Thank you so much, Uttare sir, and that's a very important take-home message for all of us. Thank you so much, sir. Have a wonderful weekend, and I would ask Bhavik to please take it forward.
Thank you.
So for the next talk, we have Dr. Alka Deshpande ma'am. She'll be talking about medical education in the COVID era. To introduce her, I would like to call upon Dr. Shailesh Chata, who will be chairing this session. He's an ex-professor of medicine with Sir J.J. Hospital and GMC Mumbai. He's a senior consultant physician and a postgraduate teacher and a guide. Jadhav sir, on to you, please.
Thank you. First of all, I must thank the eMAPCON committee. I want to introduce Dr. Alka Deshpande, who was my teacher. She is a Padma awardee. She was the HOD and Professor of Medicine at Grand Medical College at Sir J.J. Hospital, Mumbai. She was NACO Center in charge also, and she was a founder president of MAPCON in 1993. She has numerous publications and presentations. I hand over to Madam for her speech.
Thank you, Dr. Jadhav, for those kind words. First of all, at the outset, let me salute all the frontline warriors, particularly all my young resident doctors and the young lecturers who are very courageously managing this epidemic. My hats off to you, and we all are proud of you. One minute. Okay, next. Now, I remember in 1981, a pandemic started. After a very, very long time, a pandemic started, which was in 1981. It was a single-stranded RNA virus that was HIV, as you all know. There was a panic, the same reactions that we see today. But within a few years, we had a lot of information about it, and we had drugs also about it. At the turn of the millennium, it is Dr. Morin and Dr. Anthony Fauci had predicted the threats to human health and global stability, the emerging infectious diseases, the inevitable but unpredictable appearance of new infectious diseases has been recognized for millennia, well before the discovery of causative infectious agents. And that is affecting not only the health, but the economic stability of the society. ICMR last year declared that Ebola and 9 other viral diseases pose a big threat to India. These emerging infections are taking a very heavy toll. 17 million people succumb every year, of which 7 million from Southeast Asia. And mind you, all these are single-stranded RNA viruses. In addition to that, there is this new, shall I say, a discipline has come up, and that is bioterrorism. Deliberate release of infectious agents by dissident individuals or terrorist group is easy to produce, causes mass casualties, difficult to detect, widespread panic, and there is a civil disruption which serves the purpose of this terrorist group. So what are going to be the challenges for us in this decade? The challenges will be new infections, particularly from the viruses, both natural and man-made, and also from the resistant bacteria. In addition, there is going to be a challenge from artificial intelligence. All of you are reading about artificial intelligence. It is at our doorstep. Is it going to be the substitute for the doctors? I don't think so. It will play a complementary role because after all, human brain is supreme. At the launch of Sputnik vaccine in Russia, Mr. Putin gave priority to doctors. He said, I must protect my doctors first because they are taking care of the health of the society. He also said it takes 30 years to make a doctor, 8 to 10 years of rigorous medical education. Therefore, he also admitted that there is no substitute for doctors. So if we want to have competent doctors to take care of the health of the society, we have to have a quality medical education. And that is what I'm going to speak, medical education in COVID era. Now, when there is a pandemic crisis in any healthcare setting, there is a healthcare crisis, and this healthcare crisis, initial focus will be on the immediate life-saving action, rightly so. But parallel to it, we should also avoid collateral damage. Somehow that is being neglected. There is an impact on the care of unrelated conditions, and there is also an impact on medical education. SARS-CoV-2, the COVID-19 pandemic, has pushed the world into quarantine. COVID-19 has become a singular priority of healthcare delivery, rightly so. All doctors are engaged in the COVID patient care. All the manpower is mobilized for the task. Non-COVID patient care is profoundly disrupted. About the manpower, there was a shortage of manpower in UK. They fast-tracked the final year students, passed them as MBBS, and required their help, either voluntarily or on payment, for a pandemic work. Even in India, we were compared to summon medical students for the work. There was no time even to train them in donning and doffing the PPEs. As a result, some of them got affected because of this contagion. There was a movement restriction. Now, to curb the viral spread, several countries instituted nationwide lockdowns, borders were sealed, social distancing measures. As a result, it caused suspension of classroom teaching in all the educational institutes, right from play schools to universities, for uncertain time, because neither the arrival nor the departure of this virus is known. There was an academic stress to the medical students. In addition, there was a non-academic stressors also. What was the academic stress? Graduation timeline, they were adversely affected. The financial liability, and there was housing insecurity. Now, in our country, there are large many hostels attached to the colleges, but there are many colleges where the students are renting a house and staying. Abroad, that is the usual practice, and therefore there are these non-medical stresses. Medical academics adversely affected. Educational activities are suspended all over the world. Undergraduate, postgraduate teaching or lecture programs suspended. Clinical clerkship rotations are suspended because we don't have PPEs to provide to each and every student. Plus social distancing, we don't have the solutions for all this at the moment. And therefore, all these activities were suspended. It has suddenly halted the research activities. What are the lessons learned? Now, these are the lessons from Singapore, who faced SARS earlier, and therefore they have said that the pandemics can be prolonged. It is not a definite period of time, that 3 months or 6 weeks, it is prolonged. High quality non-pandemic medical care is still a priority, and disruption to various functions can be reduced through technology. Because they have gone through this, they have developed their own technology, and they could immediately switch over to these things. What is the what was the alternative? Remote teaching. The developed world switched over to digital mode. Remember this, learning consciously to live with the disease, and that is what they have learned. Necessity of adaptive novel teaching and learning methods. Now, it won't be a teacher-student relationship. It will be a facilitator and the learner. There will be virtual teaching programs, online lectures. Previously, all those didactic lectures, particularly in preclinical, paraclinical subjects, now they have been shifted to online. Instead of 1 hour long lecture, it will be short videos, because the attention span of a student is 35 to 40 minutes in a lecture room, but on a computer, it may be hardly 20 minutes. So online lecture, tutorials, short videos, virtual cases, and simulations, they are all being practiced. They are archiving the videos of the surgical skills. Now, how about clinical skill? Are we going to palpate, auscultate? What are the gadgetries that we are going to use? And here, the artificial intelligence will come to our rescue. To educate and graduate competent health professionals, we have to now make adaptations of the curriculum. Whatever is relevant, we will take it. Guidelines for using technology, assessment adaptation, because how are we going to conduct their exams? So we'll have to develop new tools, impact on the students and faculty. There will be innovations and flexibility. There will be new norms. Previously, the norm of a medical education was patient-centric. Now it will be student-centric approach integrated with clinical and scientific principles. It will be competency-based education, self-directed learning. All of you would agree with me that when we were students, we were spoon-fed. Now it will be self-directed learning and team-based approaches. Now, this is all very good. It sounds very good, and people have made progress in the developed countries. What is the scenario in India? Medical education in India, the number of medical colleges are 542, government 279, private 263. Every year, we are admitting more than 80,000 medical students. Every college has a capacity to admit 50 to 250 admissions per year. Just see the huge number. How are we going to deal with them? We have built our lecture halls, we have built our laboratories, we have built our hospitals based on this capacity of intake. We have lecture halls accommodating 200 students, but there is no social distancing. Are we going to rebuild it? Is it possible overnight? No. And therefore, we'll have to go online. Government, there is always a resource crunch. Now, teaching is an art, but skills can be cultivated by training, teaching skills. And therefore, there is already a teaching technology unit in every medical college. It should be functional, and now we'll have to adopt the new technology. What are the students' perspective about this online teaching? 51% of the students, and these studies have been done in African countries, in the Arabian countries, and also in South America. 51% of the students preferred classroom teaching. They feel isolated due to shift from medical school to home setting. Many a times they don't even have a place to sit in the house for 4 hours continuously watching their computer. They miss the discussion with the peers. In addition to contents, the body language, the approach, the interpersonal communication with the patients and the students from their teachers have an imposing impact. And that is where they develop their so-called role model. What is the another scenario in our country? You know, we are not talking about only metros. We are talking about all medical colleges in the distant areas of our country. Is every medical student having a laptop? Is there an uninterrupted internet? Do we have high-speed internet? Power supply is a great problem. Now, there was a training program online, you know, telemedicine, and there was training program in radiation oncology. And they have done the audit and shown that 20% of the time there was a power problem, while 80% of the time the faculty didn't turn up. Now, this is our scenario. There are family anxieties. Now, as these infectious pandemics will increase, there will be family anxieties. Prior to college admission, anxious parents are worried about educational activities in face of infectious diseases. And there is a big concern about safety. I remember in 93, 94, when JJ was the biggest AIDS center, parents used to come and ask me, should we take admission in JJ hospital? What about HIV patient? And I had to counsel them and tell them the modes of transmission. And I used to tell them, when your son becomes a doctor and a HIV positive patient comes, who doesn't know, who doesn't tell anything, then what will you do? He is going to manage this case. Similarly, for these infectious diseases, we'll have to allay anxiety of all these people. Otherwise, there are large avenues available for today's students. So if we want to have good doctors, we have to take this proactive role also. What are the strategies for low and middle income countries? Now, there are huge efforts are needed to move all face-to-face activities online. Just imagine what will be the Herculean task to move everything online. The faculty development is most important. We are all old timers. We only know didactic lectures. We know bedside clinics. So faculty development in the new era is most important. Familiarize the students to new technology, and therefore IT collaboration is a must. Without that, we cannot move forward. And therefore, now we have to plan something. We have to plan some short-term plans and the long-term plans. Okay? The short-term plans and long-term plans, because we don't know how long these pandemics are going to last. Now, this COVID has taken a very long time. Next year, there will be some other pandemic. Last year, there was Nipah in Kerala. There was some outbreaks in Rajasthan. So therefore, we have to be prepared and we have to have a long-term plan. So therefore, we need a high-power committee of educationists, medical teachers, IT technocrats, representatives of students, because students also must have a say in the matter, and of course, the administrators. What do? We develop a realistic curriculum. Gray's Anatomy was a Bible for us when we were students. Today, Gray's Anatomy is kept as a showpiece in the library. And therefore, we have to have realistic anatomy. What they need, only that will be taught. The same thing, we have to make the adaptations. Dissemination of information is important. Development of skills and competencies in the clinical procedures is very, very important. And we have
Madam,
to
there are
find out
5 minutes remaining.
Yes. Appropriate assessment tools, technology has to be developed. Now we have Dr. S.V. Kulkarni, who is a stalwart in telemedicine, holding workshops in telemedicine in every ePACON for last 5 to 6 years. We need such people who know the technology and who also know the needs of medical teaching. Now this is just for the road, because Naneshwar Mauli used to say, Vaktrutva avadhana chara. A speaker is inspired by the audience. If anyone keeps talking into air, thinking there are 100 people around listening, we used to call it delusion, but now it is called as webinar. So thank you for your patient listening. Thank you very much.
Thank you, madam, for the presentation. I don't think there must be any questions around, because you explained the importance of medical education so lucidly and in a simple manner, so that everybody must have learned a lot from this. Thank you, madam.
Dr. Jadhav, the chairperson, I would request all the members of the association to make some contribution for uplifting the medical education in this COVID era and in the in the next decade when we are going to face these problems. So whatever their thoughts are, I think the MAP should take an initiative to collect these ideas. Thank you very much.
Thank you so much, madam. Thank you so much for a
Thank you,
wonderful
madam.
talk. Bhavik, can you take it forward, please?
Yes, sure. So for the next talk, we have Dr. Rashad Hegde. He's going to be talking about COVID pathophysiology. I would like to call upon Dr. Umesh Pingale, who would be chairing this session. He's a senior physician from Satara. He's an ex-MAPCON coordinator and also a prolific speaker and a poet. On to you, sir. Umesh, sir.
Hello, Pingale, sir.
Should I start?
Yes, sir. So, Pingale, sir, you'll have to unmute yourself.
Should I go ahead, Dr. Singh?
No, he will just introduce you. Dr. Hegde, just give me 1 minute and to get Dr. Pingale on board. Dr. Pingale, are you there?
Yeah. Can you hear me?
Yeah, we can hear you.
Yeah. Okay. Okay. Good evening. Good evening, all my friends. Thank you, Dr. Rajadaksha, Dr. Mahavarkar, and all my organizing committee members of MAP to arrange this very intellectual feast. Today we are having Dr. Ashit Hegde. He is a consulting physician working at Hinduja Hospital. He is going to share his experience and knowledge regarding COVID pathophysiology.
Thank you very much.
Yeah, Hegde, sir.
Thank you. So I won't take much time. I won't waste time because we have very little time. So that's the SARS-CoV-2, which is a beta coronavirus. Beautiful, but like many beautiful things, quite deadly. So what is the anatomy of this killer? We know it's a single-stranded RNA virus. It's called a positive sense virus because it does not require messenger RNA for transcription. It's covered by a protein called the nucleocapsid protein, and it is enclosed within a lipid bimembrane, which is why, because this lipid membrane is easily destroyed by soap, which is why hand washing is so easily kills the virus. And then there are these three proteins which straddle the membrane. Two proteins called the membrane protein M and the envelope protein E are responsible for the structural integrity of the virus. And then, of course, the most important protein, the spike protein jutting out of the virus, giving it its characteristic bomb-like appearance. And it is this, affinity of this spike protein for the ACE2 receptor present on so many cells in our body, which is responsible for all the problems. So this is the spike protein, and this is the ACE2 receptor present on especially the respiratory cells, but on so many other cells of our body. So as we all know, most situations, it is, the virus enters the body through the nasal epithelium, because the nasal epithelium also has, the ciliated cells of the nasal epithelium have the receptors, the ACE2 receptors for the spike protein of the cause virus. So they come into the nose. But in most situations, more than 80% of people, the innate immunity is enough to take care of the virus, to clear the virus from the nose. And so most people have a very mild illness. It's only in a small percentage of people where the virus is able to evade the innate immunity. And then because of microaspiration, the virus can move down into the respiratory system. It can move down into the airways and then into the alveoli. Now, once it reaches the alveoli, it basically again has an affinity for the alveolar cells, especially the type 2 alveolar cells, which are the precursors of the type 1 cells. And it basically ultimately enters the cell again through the ACE2 receptor. But for its entry, it also requires a protein called the transmembrane protease SS2, which primes the ACE2 and helps its access into this alveolar cell. Once it enters the cell, the alveolar cell, basically what it does is it releases the virion, releases RNA into the cell. Some of the RNA from the virus is translated into the cells, into the proteins by the cell's machinery. So it hijacks the cell's machinery to replicate itself. And then these proteins form a replication complex to make more RNA. And in the Golgi apparatus of the alveoli, these proteins and RNA are assembled into a new virion, a new particle is formed, and that particle then emerges out of the cell and goes on to infect an adjoining cell. So this process keeps continuing. That's how it does. Basically, once it enters the cell, this virus takes over the entire cell and replicates itself, and that's how it spreads from cell to cell. Now, once a particular cell is, affected by this virus in the respiratory epithelium, the alveolar cells, it undergoes what is called pyroptosis. Pyroptosis is something like apoptosis, but whereas in apoptosis there is no inflammation, pyroptosis is cell death, programmed cell death with inflammation. In an attempt to prevent, multiplication and spread of the virus, that particular alveolus which has been affected by the virus undergoes cell death. But when it undergoes cell death, it expresses what are called as damage-associated molecular patterns. And this some molecular patterns are recognized by the adjacent, alveolar cells, by the adjacent epithelial cells and the endothelial cells. And these cells then secrete chemokines, which attract the T cells, the monocytes, the macrophages, and the cytokines to that area. After these, cells of immunity and the cytokines come to that area, one of two things can happen. Either there's a healthy immune response. Healthy immune response basically means neutralizing antibodies are formed which bind and inactivate the virus. The alveolar macrophages clear up the neutralized viruses. The macrophages recognize and phagocytize the apoptotic cell. And the CD8 cell mediates an efficient immune response. In which case, all these things, if there's a healthy immune response, ultimately they end up clearing up the virus. The patient has a mild respiratory illness and no damage is done, not too much damage is done. But in a small percentage of people, probably 7 to 8% or less, there is a delayed and usually a dysfunctional immune response. It basically means there's an excessive infiltration of monocytes, macrophages, and T cells. There's something akin to a systemic cytokine storm. There is non-cardiogenic pulmonary edema and the pneumonia classic of ARDS. And not only to the lung, this inflammation can spread outside the lung and cause multi-organ damage. So this really is, this dysfunctional and delayed immune response is what is responsible for the severe manifestations of COVID-19. So just to again summarize, basically you have the infection by the ACE2 and TMP. Then you have, normally you have basically, if it's a healthy response, there's clearance. But in some people, there is a delayed and a hyperinflammatory response. Ultimately, it can go outside the lung and cause multi-organ failure. Now, once the cell gets hold of the virus gets hold of the alveoli, it can cause damage in one of four ways. The first way, of course, is directly the virus can damage the alveolar cell, that is direct cytotoxic effect. Then there are two or three other mechanisms which I will talk one after the other. One is dysregulation of the RAS, second is endothelial cell damage and thromboinflammation, and then the dysregulated immune response. So we all know that we know all about the renin-angiotensin system. Basically, we know that the renin angiotensinogen is secreted by the liver, and renin converts angiotensinogen to angiotensin 1, which is then converted by angiotensin converting enzyme to angiotensin 2. Angiotensin 2 basically is called vasoconstricting, it's pro-inflammatory, pro-oxidative, and pro-fibrotic. Basically, a lot of damaging effects to the lung. But to some extent, angiotensin 2 is countered or balanced by the actions of ACE2. ACE2 converts angiotensin 2 and angiotensin 1 to angiotensin 1 to 7. And angiotensin 1 to 7 has exactly the opposite effects. It causes vasodilatation, it's anti-inflammatory, it's antioxidative, and antifibrotic. Also, ACE2 to some extent affects the levels of bradykinin. It decreases the levels of bradykinin. But it is found that in COVID-2 infections, because the attachment of SARS, the S-spike protein to the ACE2 and the internalization of this complex, ACE2 gets down-regulated in SARS-2 infection. Therefore, the balance is not set. The balance now goes more in favor of increased levels of angiotensin 2, decreased levels of angiotensin 1 to 7. So, which is why there is more vasoconstriction, more pro-inflammatory effects, more pro-oxidative, and more fibrotic effects. But in the lung, sometimes there is vasoconstriction, but in some areas, because of the bradykinin, because of nitric oxide released by the inflammation, because of reactive oxygen species, there also is vasodilatation. So, like in sepsis, there are some areas where there is vasodilatation, there are some areas where there is vasoconstriction. Similarly, initially in the pulmonary circulation, there is something akin to sepsis where some areas are vastly vasodilated and some areas are vasoconstricted or blocked. Then, of course, very, very important, something that everybody knows about, coagulopathy in COVID. COVID, basically, this is supposed to be something called an endotheliitis, because the endothelium itself also has ACE2 receptors, which can basically then, which the SARS virus can attach itself to the endothelium and causes endotheliitis. So basically, there is coagulation both because of upregulation of inflammation and because of upregulation of the coagulation cascade. Much like in other sepsis, there is the tissue factor gets expressed, fibrinolysis gets suppressed, platelets get activated, von Willebrand factor gets up, numbers go up, factor VIII levels go up. So basically, somewhat akin to other sepsis, but this is a little more. Patients with COVID were much more coagulopathic than conventional sepsis, probably because of the direct damage to the endothelium as well. And because of this, of course, it's manifested by direct in situ thrombosis in the pulmonary circulation. It can cause major pulmonary thrombosis, it can cause strokes, it can cause mitral infarction, and so on and so forth. And the fourth arm, of course, the immunopathology of COVID, the dysfunctional immune response. Basically, the immune response in severe COVID-19 is characterized by severe lymphopenia. We all know the lymphopenia is a marker of a poor outcome. This lymphopenia, CD8 cells and CD8 cells are decreased. Natural killer cells are reduced. Lymphocyte dysfunction is there, but there is an increased, vastly overproduction of the inflammatory cytokines. There is neutrophilic leukocytosis when there is a cytokine storm, but the monocytes, eosinophils, and basophils might be decreased. There are increased antibodies, but these antibodies are not neutralizing antibodies. They are non-neutralizing antibodies. Therefore, they actually cause worsening because they are like in dengue. They cause antibody-dependent enhancement. Basically, they allow the virus easy entry into the cell by attaching itself to the Fc receptor of the antibody, but they don't neutralize them. So actually, they make matters worse. So this is what happens in the dysfunctional immune response, which is usually a little delayed and too bad. So that's about the bit of the pathophysiology. What we really need to know is about the most important manifestation, of course, of severe COVID is severe hypoxemia, which is the main reason why almost 80% of them who have severe COVID come to the ICU. Now, these are two different, CT scans, one showing actually relatively mild changes in the lung, and the other one showing, of course, more than 50 to 60% of the lung is affected, but both of them have almost the same degree of hypoxemia. So what is the reason for this? Why do people, at least initially on with relatively normal X-rays, relatively mildly abnormal X-rays, have such profound hypoxia? Whereas, of course, you can explain the second X-ray where somebody has, almost 50 to 60% of lung affected. You can explain the hypoxia in him. But why the first person has such profound hypoxia? This can be explained if you know about hypoxic vasoconstriction. We all know that normally, whenever an alveolus, gets very hypoxic for whatever reason, the blood vessel supplying that alveolus vasoconstricts. therefore matching ventilation with perfusion, which means when an alveolus is not ventilated properly, even perfusion to that alveolus gets decreased. Therefore, ventilation and perfusion are matched, hypoxia is prevented. But what is the theory that is in early COVID-19? Probably there is loss of hypoxic vasoconstriction, which basically is responsible more than actual alveolar damage. Alveolar damage is there, but not too much. It's very peripheral and not too much. The main reason for hypoxia early on at least is absence of hypoxic vasoconstriction. There continues to be vasodilatation, which is why if you notice these people, even the slightest exertion, when there's increased cardiac output, when there's increased transit time, they desaturate very, very quickly, which is this seems to be the predominant mechanism for early hypoxia in people with severe COVID-19. Later on, of course, there's a different factor. In addition to the hypoxia, these people, obviously because of hypoxia, they have an increased respiratory drive. So they breathe faster, they breathe deeper. But because the lung is not badly affected, the compliance of the lung is not bad, which is why they don't need to, they don't feel dyspneic. They would feel dyspneic if the lung compliance was affected. But because the lung compliance is not good, though they take deep breaths, though they breathe faster, they don't feel breathless, which is why we call this hypoxemia. But ultimately, these deep breaths, these faster breaths can induce, increase in, what are called transalveolar pressures, can contribute to worsening lung injury. So over time, direct toxic cigarette damage caused by the virus, along with this severe negative pressures, what is called as patient self-induced lung injury because of deep breaths, because of increased transalveolar pressures, over time can further damage the alveolus, and finally the patient can develop a phenomenon similar to classic ARDS, where the classic AR 60 to 70% of lung is affected, the compliance is poor, they require high levels of PEEP, whereas early on the compliance is good, they don't respond very well to PEEP. So that is why the strategies for management vary depending upon where the lung is compliant or not. And early on maybe they don't respond very well to PEEP, they will get away with a higher tidal volume. Later on you'll have to treat them almost like classic ARDS. Now that was about the lung, but in the absence of time, I really won't talk too much about other systems. But we know that other than the lung, ACE2 is expressed in several cells of the body. It's not just in the lung, in the CNS, in the upper airways, in the vasculature, in the liver, the eyes, the heart, the kidneys, the gut. Now, basically, the mechanism of injury, by and large, in all these organs is probably more or less the same. To some extent, there is direct cytotoxic damage. To some extent, there is endothelial blockage because of thrombosis. To some extent, there is the inflammatory cytokines causing damage. So it's almost more or less the same pathophysiology affecting most of the organs. I'll just talk very briefly about some of the common organisms. The kidney, at least initially in China, they didn't report too much about kidney damage, but from the West and certainly in our country, a significant proportion of patients have kidney damage at onset. While some of these people might be volume depleted at onset, probably because of diarrhea or poor intake or because of rapid breathing. Most of these people seem to have direct endothelial damage to the kidney. Some of them have some amount of globular damage. Some of them have blockage of the renal vessels. And some of them, of course, maybe because of, decreased cardiac output as a result of mechanical ventilation of ECMO or micro dysfunction can have, pre-renal causes. But by and large, majority of patients, the cause of renal failure really is direct damage by the kidney, either to the tubules itself or to its vasculature. And treatment essentially probably is only supportive. Of course, initially, if you think the volume depleted, you need to fill them up, but otherwise, probably you don't need to overdose the fluid. You just have to support them. Many of them might require renal replacement therapy. And of course, other things, of course, many patients have cardiovascular problems. Again, the cardiac, we should know the myocardium has several, ACE2 receptors, Therefore, again, the myocardium can be directly affected by the COVID virus because the spike protein attaches directly to the ACE2 receptor of the myocardium. So you can have a direct myocarditis. You can have hypoxemia causing myocardial ischemia and causing myocardial dysfunction. Sometimes because of, increased cytokine storm, there's increased demand. There's not enough blood supply to the heart causing hypoxic dyscompression. Also, these people, again, the endothelium of the myocardium can get affected, leading to acute coronary syndrome. And there's several reasons. So basically, the manifestations of cardiac could be an acute coronary syndrome, myocardial infarction. They come with an arrhythmia, quite often atrial fibrillation. They can even have dangerous arrhythmias. They can have myocarditis. They can have something akin to a Takotsubo cardiomyopathy. And of course, they can have venous thromboembolism and right-sided failure and heart failure and cardiogenic shock. But by and large, though there is a myocarditis, though the troponin levels are quite high, by and large, LV function doesn't decrease that much in patients who don't have, classic infarction. If they're just a myocarditis, by and large, systolic function doesn't decrease that much, even though the troponins, etc., rise. So like I said, I don't have time to cover most of the other, systems that have been affected by COVID, but basically we know that it affects the nose, it affects the kidney, the liver, it can affect the pancreas, causing, sugars going haywire. A lot of people come with diabetic ketoacidosis as the first manifestation. Some of them come with hypoglycemia as the first manifestation. We know that the eye affected. Of course, we know that the brain also is affected quite often in COVID. Classically, of course, the anosmia, but the other symptoms also can be affected in COVID. So to conclude, these are supposed to be the so-called four horsemen of the Bible. Talk to them about the four horsemen of the apocalypse. Apocalypse, of course, when time comes to when the end of the world. So that is conquest, war, famine, and death. These are supposed to be the four horsemen of the apocalypse. And similarly, according to this paper, these are the four, horsemen of the COVID apocalypse: dysfunctional virus, a sneaky virus, a dysfunctional coagulation system, a dysfunctional angiotensin system, and a dysfunctional immune system. Thank you. I think if any questions, I shall be happy to answer them. Thank you.
Okay, thank you. Thanks, Dr. Hegde, sir. Your elaboration is very clear. It is you have explained everything regarding how damage to the endothelium occurs, what is the inflammatory and immune response, what is coagulopathy and sepsis in COVID infection, and how it leads to multi-organ failure. Thank you. Thanks for your lucid presentation. We will have one or two questions. If anybody is having questions, please. Hello.
So we have not on the chat box received any questions, sir.
Okay.
So I think, so I think we can proceed ahead.
Thank you.
Okay, thank you. Thanks a lot.
Thank you, Dr. Hegde, for a wonderful talk.
Thank you. Thank you.
Thank you.
Bhavik, can
yes,
you take it forward, Bhavik?
Yes, sir, sure.
Thank you. Thanks.
So for the next talk, we have Dr. N.K. Singh, who will be presenting COVID management, time is a game changer. For that, I would like to call upon Dr. Prakash Bhatkamkar. He is a senior physician from Thane, a past president of MAP and past president of API Thane. Dr. Prakash, sir, on to you, please.
Bhatkamkar, sir, you'll have to unmute yourself, please, and turn on the video. Dr. Bhatkamkar?
Yeah, I cannot start video. Host has to start the video. I have unmuted myself.
Okay, you can carry on, so we can hear you.
Welcome, Dr. N.K. Singh, to eMAPCON. Sir is a senior associate or senior physician and cardiologist from Dhanbad. He has numerous publications to his credit. He is a faculty position and as a national speaker. He will be talking to us about COVID management. Welcome, Dr. N.K. Singh.
Good evening, Chairperson, sir. Let me share my screen. I think it is visible.
Yes, sir.
It is visible.
Yeah, fine. So, first of all, I am really thankful to this excellent webinar which is going on. I think this is the first webinar I am attending which is on time. Everything is on time. So, thank you very much for inviting me. My all dear colleagues and chairperson, sir, and all the organizing team. I think you have given me a very relevant topic, the COVID management, and time is a game changer. So really, time matters so much in this management of new disease. But I must have my disclosure that I am not a COVID expert as such, but basically a diabetologist, but a physician. But I am a track of moderating COVID medicine through my WhatsApp group known as CME India group. So what we are looking for in this COVID era, the first thing is that timing is important. When to initiate antivirals, when to initiate steroids, and when to initiate anticoagulants and high flow oxygen, that is known as the superhero. So it should not be delayed. It should be on time, not should be delayed. But the problem which we are facing, we do not know which bells are ringing in tune. Is it the hydroxychloroquine, steroid, the FEBI, ivermectin, anticoagulants, or very recent the controversy which came with the remdesivir? So this is the real problem which our physicians are facing all over the world. As far as timing is concerned, my point of view is that the identification of day 1 of symptoms is the most vital in clinical guidance of treatment initiation in COVID-19. And many times I have seen that we fail to catch that point of the day 1. Because it is very well known today, and this is the latest East Virginia Medical School guideline, that the timing of the initiation of anti-inflammatory therapy, how they are saying, you can see here, if at all you are using the antivirals, the days has been shown here. Incubation period and symptomatic phase. Then comes the time course you are showing in the days here. Then they start the early pulmonary phase and later is the late pulmonary phase. Accordingly, the things changes. So recognizing the day 1 and the most frequently reported signs and symptoms of patients which have been found in India is fever, usually of low grade, very common. You can see cough, dry throat, dry cough, myalgia or fatigue, maybe in the 11 to 52%. And as loss, the loss of smell is known as nose corona, loss of taste, throat corona, shortness of breath, and lung corona, and happy hypoxia we have seen in many cases. And low hand grip strength and 6-minute walk test plan 3 to 6, 5% desaturation. So any symptoms with close contact, and accordingly you have to catch this day 1, and accordingly you will then go for the start the thing. So what you are going to plan on day 1? Suppose once diagnosed or suspect, I feel that at day 1, do a baseline minimum quantitative CRP, CBC, blood sugar, ESR, 6-minute walk test. And also many experts' opinions is now there that we should also have a baseline ferritin, D-dimer, if possible IL-6. These are the basic things. As far as the starting of drugs is concerned, I will not go in very details because this becomes a very controversial topic today, whether you should give azithromycin. The ICMR and Ministry of Health has told no to the ivermectin at all. Vitamin C, zinc, everybody you are prescribing. Melatonin, I think in India, we are not using too much, but in USA, there is a trend. You are using FEBI, famotidine, might be some patients are using, we are using paracetamol, but some people are also using the mefenamic acid and they have found it good. But the most important thing is, if suppose on the day 1, if there is a percentage in the high risk category, then there has been recommendations from the Indian experts to start the blood thinners like Debigarten or Rivaroxaban or Piximab, or if hospitalized, if patient is serious from the very beginning, then the low molecular weight heparin. Aspirin may not be helpful in big viral load, remember, and we do advise to do a 6-minute walk test and CRP daily on day 1 to 5. So this is, I think, the basic things. But in many parts of the world, they say nothing worse, so do nothing. But I don't think that this should be at present our principles to treat the COVID at present. Then we should also be very careful to categorize your patient into mild, moderate, and when it becomes the severe. So how to do that is the big challenge. Everything has been, our first speaker has excellently told about this hematological things, inflammatory markers, immunological markers, and biochemical markers. I will not repeat. But in India and in many parts of our state here and other parts, I have found that even if you do a ferritin, LDH, CRP, and very cheaper tests like lymphocyte count, neutrophil count, and NLR ratio, this serves the purpose of treating our cases. Recently, something has come with the interleukin 6 and interleukin 10 ratio, but in India, I have not seen someone using it because you are not going to estimate at present IL-10. But again, there is very excellent topic already covered, when to do HRCT. A storm is brewing as far as the city thorax is concerned. So it is has become very important to make intelligent use of HRCT as a diagnostic tool. But if high risk with comorbid conditions, start low molecular steroids on day 3. Many times I have seen in the webinars people talking about using an early steroids, which I do not believe is will be appropriate at present to say. But if there is an evidence of pneumonia, as evident by fever more than 101 Fahrenheit, CRP more than 10, cough starting on day 3, and fall in SpO2 saturation by 4% or CT proven, I think we must start low dose steroids on that time, because lots of studies and observations have showed that the consequence of steroid avoidance, early steroid avoidance on CT scans can lead to, although we don't have a proof at present, but observations based, I can say that the AVMS guidelines comments if steroid were given early in such cases, might we have avoided such conditions which becomes irreversible. Then the concept of IL-6 and IL-10 ratio might be very useful in days to come. As you know, the interleukin 6 is a pro-inflammatory, but interleukin 10 is anti-inflammatory. And level of both are altered in severe COVID-19 patients. So new concept is that do not focus solely on increased baseline levels of IL-6 in COVID-19. It may be more useful to view longitudinal inflammatory biomarker levels as features of a more comprehensive shift in metabolic and inflammatory balance. So what to do? They have developed a scoring system like Boston scoring system, where they take ratio of IL-6 and IL-10, which is not very difficult things to do. They don't have developed an apps at present as far as I know. So what they do, that this is the first COVID-19 specific prognostic scores now available to guide clinical decision making. This accurately predicts how severe the infection will be on day 7. We have to measure the patient's blood for the first 4 days. Remember, you have to measure IL-6 and IL-10 for the first 4 days, and accordingly you can predict if there is 4-day change in the IL-6 and IL-10 ratio, then you can predict that patient is going to be critical or severe. So I think this is a very important thing again. But this is not possible, I told you, in our parts at present. So what is the practically widely available game changers? They are the clinical and biochemical parts, like lymphopenia is found in 80% of critically ill patients, and only 25% of patients with mild COVID-19 infections. In the same way, already our first speaker excellently told about the eosinophilia may not be associated with an unfavorable progression of COVID-19. And NLR has been identified as a prognostic biomarker for patients with sepsis. So this you are well aware. Then already the platelet count, the CRP, ferritin, that has been covered. But LDH is also available everywhere. So an increase in LDH by 62.5 units per liter has an acceptable sensitivity and high specificity for a significantly higher probability of disease progression. So LDH is a potentially useful follow-up parameter in COVID-19 pneumonia, which might assist in recognition of disease progression and thus help in risk stratification and early intervention. So this is also an important, because the increase in LDH is a sign of cell death. Remember, then procalcitonin, as you know, is also has become very important to predict the occurrence of sepsis. So I will not go in details of that. So in the timely prediction in severe disease, WBC saw lymphocytopenia affecting both CD4 and CD8 cells, as well as a decrease in monocytes and eosinophils and a clear increase in neutrophils and NLR, and markedly higher concentration of, if you see, ALT, AST, creatinine, CK, LDH, cardiac troponin, anti-BNP-pro, and D-dimer, they are clearly good severity predictors. And current clinical practice suggests that the determination of IL-6, D-dimer, LDH, and transaminase, remember these things, in addition to routine laboratory tests, is useful in the high-risk patients. So these things must be remembered. So these are in fact not only predictive of disease severity, but also very important for the therapeutic management based on drugs preventing the activation of coagulation process, and this must be clearly understood. A laboratory score taking into account the hematological, inflammatory, biochemical, and immunological parameters would help to stratify COVID-19 positive patients into risk categories, which would be of utmost importance in the clinical setting and the therapeutic management. So let us come at a glance at a day 5. If the patient has got all these things abnormal, be very careful, and this is the time you should start the most important nectars today we have, like anticoagulants and steroids, because then comes the pulmonary phase. And this is the first 4 to 5 days is the early pulmonary phase, and next is the late pulmonary phase. So the pulmonary phase or respiratory phase is the phase of inflammatory response due to the presence of viral debris. After symptomatic phase, virus is non-replicable and non-culturable. If viral load is more there will be huge viral debris, and those will cause severe inflammation in the host cell, remember. So early pulmonary phase of thrombophilia for 3 to 4 days, it is a condition of where there is an imbalance in naturally occurring blood clotting proteins or clotting factors, and this is a very, very vital point to understand. A timing as game changer to sense the red flag signs, and you are well aware and how to we start these things with antivirals, anti-inflammatory. We will discuss in short how their viral application is going from day 1 to here, day 9 or 11. Then there is viral debris in the early pulmonary phase. Immune dysregulation is going on. Cytokine storm could occur, and the T cell dysfunction can occur. And accordingly, you get the ground glass infiltrates here. You can see clinical symptoms, starts fever, malaise, cough, but here in the viral debris, how mild hypoxia occurring and progressive hypoxia. And then if at all you are going to use the antivirals, to start here. And anti-inflammatory at this point is must. Potential therapy is a ivermectin, I don't know. Everyone is using, but it has not been recommended by the authorities so far. But we will discuss. So remember, every should be aware again and again about the fever with drugs more than this, without antipyretics. Persistent cough starting after day 3, remember. Persistent cough starting after day 3. Sudden onset of shortness of breath. Rapid rise in CRP. And more than 50% of lung involvement on CRT and altered sensorium is very much important to become alert. As far as the management is concerned, this is the NIH guidelines recently released. And I think this is quite scientific, because this is the has been taken care by many societies, and they've been given a recommendations that if the patient is not hospitalized or hospitalized but does not require supplement oxygen, they say no specific antiviral or immunomodulatory therapy is recommended. And at this time, the panel recommends against the use of dexamethasone. But if the patient is hospitalized and requires supplemental oxygen, then they have recommended remdesivir 200 milligram IV for first day, and followed by remdesivir 100 milligram IV once daily for 4 days or until hospital discharge. So this has become very important, and so we published an article in our CMA India group that COVID-19 treatment, the elephant is in the room, so many confusions are there. So time for antiviral it has to be given in symptomatic phase when virus is replicable. First 8 days of symptoms are ideal for any antiviral treatment, including the remdesivir. Remdesivir today is indicated in moderate symptomatic cases, as mentioned earlier, based on reduced oxygen saturation, but patients should not be on high flow oxygenation, NIV or mechanical ventilation. And even the convalescent plasma and interferon alpha are to be given, although they are out after the PRECID trial. We will not discuss about that. And any treatment module targeting the viral antigen, including antivirals, has to be initiated in the viral replicable period I told you. So these things are quite now clear. I'm not going detail for that, but today you see here, after discharge what to do, that will be a separate time. When this solidarity trial came, then lots of discussion is going on at present also. There is 4 RCTs, simple, Wuhan, ACTT, and then later the solidarity, and whatever it may be, no benefits of remdesivir whatsoever noted in any groups of COVID, asymptomatic, mild, moderate. This was some. So I had a personal communication with the...
Things are only 4 minutes now.
Yeah, I will be able to finish. I am just... So I had a conversation with the Dr. Richard Russell, and he was saying that all the results were negative, so you need to look at the characteristics of potential responders and use their phenotype to target who to treat. Because even if the solidarity, there was no placebo, no double blinding, limited data monitoring, no diagnostic confirmation of infection, no timing of symptoms, lots of flaws were there in the solidarity trial also. So that's why...
5 minutes more, please.
No problem. I am coming to the final slides. So at present, when the FDA has now given it license as the first anti-COVID drug, so at present, my view is that it should be used, definitely not in the haphazard way, but very intelligently, and this can benefit to our patients because now it is approved as the first drug to treat COVID-19. So if at all you are using it, use it early as the saturation starts to decline, with steroids and heparin along with it as per your decision, individualized to your patients, and wait for 3 to 4 days for the clinical improvement. If clinical improvement does not occur during that period, add other therapies like immunomodulator drugs. That is a different issue. Now the timing of a steroid treatment, I told you that this should be initiated early in the pulmonary phase to counter the immune dysregulation. So ideal time for steroid initiation is after 8 days of symptoms, when virus is very low replicable and inflammatory response is about to settle down. And if the steroid is started in the early viral replicable phase, early phase of symptoms, then there is chance that virus will replicate more. So if pulmonary phase steroid has to be given and start early, that is the message. And then which steroid, methylprednisolone or dexamethasone, then again is a big debate. I have not time to discuss, but steroid treatment, right time, right drug, right dose, and right duration is very important. But now the many strategies are out showing that if you use methylprednisolone, I think the number needed to treat to save one life is here you can see is low, but if you are using dexamethasone, here you can see here. So I'm not going details of that, but remember even there are those 2 types of schools. One is promoting more DEXA, and other is that. Then the next thing is the anticoagulants, the severe COVID-19, as you know, there is DIC, BT, everybody you know. So in all moderate and severe symptomatic patients with clinical presentation of pulse rate more than 110, respiratory rate more than 24, SpO2 less than 94, either hospitalized or in home treatment, if clinically pneumonia is suspected by the history and clinical presentation of the disease or pneumonia is confirmed by X-ray chest or CT scan chest, low molecular weight heparin should be initiated on day 5, or in case of high risk group, I believe on day 1. Then there is definitely the oxygen is superhero, it should be initiated. And my final points are that the intelligent use of simple scientific facts can be extremely game-changing in COVID-19. So what are those things We can reduce mortality if we monitor each case properly from day 6 to 12. Start antivirus early. Do not use Dexa with remdesivir. There is some regions are there. AB is important in milder and severe cases. When patient is on high flow oxygen flow with flow more than 35 liters per minute, take precautions while giving disease shock in ICU, and changing positions while ventilator will help. So in X-ray, pneumonia is indicated on day 5 to 6, but the CT scan chest is visible on day 2 to 3. It has been found in some studies. To reduce morbidity and mortality, diagnosis of pneumonia should be completed by day 5. It's very, very important. And the time of steroid initiated actually is in the minimum 8th day of symptoms. This is, I have told you. And sometimes this Tolicity also, although not at present recommended, but some cases we have seen it worse, and antivirus may need to be given. So lastly, I will tell that day 5 is the day in the critical phase. You take the timely actions. And last slide is to be clear, sensible medicine does not mean clinicians should not intervene. So what to do? Rather, it proposes a gentle, moderate, and humble view of available treatment options and their effectiveness in patients with COVID-19. So in the middle is a sensible approach which acknowledges that some interventions are effective, but perhaps confidence should be tempered. With this message that the immunity is the boss in COVID-19, others are Mrit Trishna, I will end here. Thank you very much for giving me this opportunity to talk with you. Thank you very much.
Thank you, Dr. Singh, for lucid presentation. I'm glad that you have stressed many clinical points. Your main takeaway from your lecture is we should act early and look at clinical features to identify the viral implication phase and start steroid on day 5. And remdesivir when there is evidence of hypoxia and early stress. Thank you very much, Dr. Singh.
Thank you.
Yeah, thank you very much.
Thank you, sir. Very good presentation. We'll move on because of the paucity of time.
Okay,
I would ask Bhavik to please carry on.
Okay, thank you. For the next session, we have Dr. Priya Balani Thakur. She's going to be talking about the cardiorenal connection and diabetes, exploring early opportunities for intervention. For this talk, I would like to welcome Dr. Mukund Pendulkar. He's a young dynamic consultant physician and a diabetologist from Pune, practicing at Sanjeevan and Shashwat hospitals. A very well-known personality to Pune physicians, a secretary of API Pune and organizing secretary for the upcoming MAPCON 2021. Apologies. On to you, sir.
Thank you very much for this kind introduction. I think before starting this particular session, I would congratulate the MAP committee who have done a wonderful job in maybe 2 or 3 weeks itself. They have continued this particular MAPCON because we were almost hearing that there will not be any MAPCON this year. So I would introduce Dr. Priya Balani Thakur. She is a consultant endocrinologist from Bombay Hospital with over 20 years of experience. I think the Mumbai people, all the physicians know her very well. And she has numerous publications and faculty talks at national level. I think during this COVID sessions, we are going to have this session is going to be the odd man out, you can say, because she is going to talk to us on cardiorenal connection and diabetes, exploring early approaches. Over to you.
Yeah, I'll just share my screen. Are you all able to see my screen?
Yes, we can see that.
Okay. All right. Well, good evening, everybody, and thank you, MAPCON, and all the organizers for having me here today. With no further ado, first of all, I'd like to say we've heard so much about the COVID pandemic. What I'm going to talk about over here today is type 2 diabetes and its biggest complications, which is cardiovascular and renal disease, which actually are also one of the greatest pandemics of chronic disease in the world today. Now, modern treatment for diabetes started roughly around 100 years ago when Banting and Best discovered insulin. Following that, we've had many oral drugs that have come into the market. Primarily, we were taught that by the landmark trials that hyperglycemia was the main culprit. Correction of hyperglycemia, therefore, would decrease end organ damage, damage to the heart, damage to the kidneys. Macrovascular reduction, however, has been a little bit sketchy in terms of improvement with hyperglycemia control. Microvascular risk reduction is what we have been able to do with improvement in diabetes. However, in the recent past, in the last decade, numerous trials basically revealed that newer drugs now have, regardless of A1C reduction, the potential to decrease MACE risk, decrease renal risk, and improve cardiovascular mortality. And that basically is what we're trying to see, is how to connect these dots. Do we have now a new paradigm of care, early opportunities for intervention, and learning more about diabetes in itself? So the formidable burden of diabetes...
Ma'am, sorry to interrupt. We are unable to see your presentation on the screen.
Oh, all right. Sorry then. Is that visible now?
No, ma'am, not yet. Ma'am, could you click on this share screen button and then go on to your presentation? Can you just click on that?
Yeah, share screen and...
Yes, ma'am, now it's visible.
Okay, but... No, there's something wrong here, right?
Yeah, you just have to go, if you're using a Windows, can you do Control F5? Or, yeah, there's some issue with the...
Okay. Should I do a stop share again?
Yeah, ma'am, please.
So, share screen, basic, try, wait. Sorry.
It's absolutely all right.
Just give me a quick second, yeah?
Sure.
How do I share screen here? I don't know what's... Is that visible now?
No, ma'am, it's not yet.
Oh, God. So, share screen, and then it should... Read had told me if I go to advanced portion share. Here told me go into share.
Yeah, but advanced portion.
Advanced portion, then share on this. Then basically, I need to use it from...
I think that's good enough. You can continue, ma'am.
Should I do that? Okay, then just go down there. Holding down all the way, and all the way.
Yeah, we can see the slide.
Ma'am, it's perfect now.
All right. Yeah, start video. All right. Is that all right?
Yes, ma'am, it is.
Okay.
Thank
Sorry
you.
about. I apologize. Okay. So like I was saying, the most formidable burden of diabetes basically is with India and China. In the last 2 decades, actually, China has tripled its diabetes levels. India has doubled its number of diabetes patients. However, in the following 2 decades, what's expected is that the Chinese dragon, actually the Indian elephant, is going to outrun the Chinese dragon, and that is purely due to our immense urbanization. And why does this also happen? This is on our background of our Indian phenotype. Well, with the Indians, we all have this thin, fat kind of body structure. All of us have below our, thin frames, have this little bit of the central obesity, which 57% of people with diabetes have. In fact, in a particular study, it was seen that our Indian diabetics, if the BMI was compared, the average BMI of Indian diabetics was roughly around 24.4. Compared that to our Western diabetes counterparts, the BMI was 32.8. Big difference. Now add on to the central obesity in our patients with diabetes, a high risk of hypertension, and this finally results then in a much, much higher risk of complications, a 2-fold increase in cardiovascular outcomes, a lot of which of cardiovascular disease could be subclinical, a 40 to 70% increase in the risk of renal complications as well. Now, like we all know, there is a very close relationship between cardiac and renal pathophysiology in type 2 diabetes. All of these are basically the best friends. They have a lot of common mechanisms, a lot of signaling pathways, cascades behind all of them. And when any 2 of these issues are present, type 2 diabetes, heart disease, CKD, they will tend to worsen the other. So how does this happen? Type 2 diabetes, when accompanied typically by hypertension, by dyslipidemia with a prothrombotic background, results then in an increased risk of myocardial ischemia. The myocardial ischemia worsens heart function. Add on to that prolonged hyperglycemia in itself, resulting in a diabetic cardiomyopathy. And these, in addition, will result in reduced ejection fractions in patients with diabetes. Now, with the low output state over here, this decreases renal blood flow, causes an activation of the RAS, worsens the CKD outcomes also. Diabetes, like we know, in itself also directly targets the kidney, making it the commonest reason for end-stage kidney disease, and therefore the commonest reason for renal replacement therapy as well. And this whole vicious circle, ultimately, so far, we've had nothing to interrupt it, not until recently. Now, diabetes, like we also know, contributes significantly to hospitalization for heart failure and CKD. What does this basically mean? Hospitalization basically increases economic burden. It increases the chances of patients landing up in ICU, increases the health burden in terms of morbidity and mortality, and therefore, as a result of which, preventing complications to prevent hospitalization and worsening economic burden also is very important. The question is, do we have any solutions? So what happened back in 2007, basically, with the whole rosiglitazone debacle, Nissen reporting basically the adverse heart failure outcomes with the use of rosiglitazone, it was basically mandated by the FDA that all new drugs for diabetes entering the market needed cardiovascular outcome trials to establish their CV safety. Following that, basically, thousands and thousands, a large, robust cohort of patients was studied for their cardiovascular outcome trials for proving their safety, giving us more and more information, not only basically about the newer drugs in terms of their safety, but also made us connect the dots within diabetes and its pathophysiology, etc. as well. What also came out of this whole maze of trials, like you're seeing here today, is that there were certain classes of drugs, primarily the GLP-1 RAs and the SGLT2 inhibitors, that not only were CV safe, but their outcomes in terms of CV superiority were accelerating in itself. Back then, the drugs that were just coming into the market were basically the DPP-4 inhibitors, so not market, that were just coming out basically. And they, with their cardiovascular outcome trials, the very first one that came out was the SAVOR-TIMI 53 trial for saxagliptin. More than 16,000 patients studied. What came as a surprise indeed at that point of time was that saxagliptin had an increased risk for hospitalization due to heart failure, a 27% increase, and this was something that came out of the blue. Following that, basically with alogliptin also in the EXAMINE trial, remember in these two trials, all the patients actually had a higher risk of CVD. Again, over here, there was a higher risk of hospitalization due to heart failure. What happened following these two trials with the DPP-4 inhibitors was that the FDA gave an HHF label to both of these drugs. Not only that, in 2016, after this label was given, this label was in fact extended over to sitagliptin and linagliptin in spite of their neutral outcomes with the TCOS and Carmelina, where it came to hospitalization due to heart failure. Now, over all of these years, we've all used these drugs, and this HHF kind of label, though has been lurking in the background, a lot of newer data has shown that possibly this SAXA label wasn't, maybe was an error, maybe substate specific, but until head-to-head trials are done, still SAXA does carry with it the label of increased risk for HHF. The MACE outcomes, however, with the DPP-4 inhibitors, basically as is shown over here, all on the line of unity, basically showing that the gliptins were CV neutral. Now, following that came all the GLP-1 RA-SVOT. Like you're seeing robust trials, large numbers of patients. The LEADER trial with liraglutide was the first one that came in, making liraglutide basically the gold standard of therapy, sustained, like you're seeing, such improvement in terms of MACE outcomes as well. The REWIND trial with dulaglutide gave us such great information in terms of showing us that even at a low average A1C of 7.3, in spite of that, there was MACE outcome improvement, a 12% improvement as well over here. In addition to that, with the REWIND trial, for the first time, we saw that patients, even without established CVD, derived MACE benefit. The HHF data from the GLP-1 RA-CVOTs, again, majority of them basically were neutral, basically showing that there was no increased risk on that front. Now, following all the GLP-1 trials last year, there was an ADA-EASD consensus statement update, basically saying that GLP-1 RAs can be used now independently of the baseline A1C with an individualized A1C target. If MACE is the gravest threat, the level of evidence for MACE benefit is greatest for the GLP-1 RA group. And to reduce the risk of MACE, the GLP-1 RA can also be considered in patients with type 2 DM without established CVD with indicators of high risk.
Ma'am, 5 minutes left, please.
Sure. Now, the SGLT2 inhibitors, like we know, have now become the newest kid on the block with such immense benefit, weight reduction, BP reduction, less hypoglycemia, CV, renal safety, all of that put together. Like we know, the main effect, glycosuria, improves hyperglycemia, improves glucose outcomes, increased glucose toxicity. Alongside with that, 1 gram of glucose causes 4 calories of weight loss, resulting in body weight as well. The extra glycemic effects, basically due to the osmotic diuresis and the natriuresis, a decrease in plasma volume, blood pressure, and hyperfiltration. Remember that it is the glycemic effects of SGLT2 inhibitors that can be achieved with an intact GFR. However, the extra glycemic effects of the SGLT2 inhibitors are in spite of the GFR. Even patients with low GFR can derive these cardiorenal benefits of the SGLT2 inhibitors. In conclusion over here, with the CV effects of the SGLT2, what one saw was fantastic data in terms of reduction of the MACE composite, HHF, and CV death all put together. Over all of these, the EMPA-REG outcome was the first one that showed this kind of data. And following that, there has been a spate of brilliant data as well. This was demonstrated in patients across all the CVOTs, across credence, across real-world evidence, basically showing us that the SGLT2 inhibitors improved HHF, improved renal outcomes, improved MACE outcomes to a modest degree as well. With the SGLT2 inhibitors over here, ertuglofosine over here, the latest one, threw a slight googly over here because the MACE outcomes were not benefited. However, HHF definitely was. Now, with the effect of dapagliflozin on incident diabetes, this was a trial, DAPA-HF, that was done on patients with a mixture of no diabetes and diabetes. Like you're seeing over here, this was patients without diabetes with the use of DAPA in this particular group. What was basically concluded is that with placebo, 93% of patients without diabetes developed incident diabetes. On the DAPA group, this was 64%. Basically now telling us that we have a drug that resulted in a 32% reduction in the incidence of new onset diabetes, probably a drug that prevents diabetes onset as well. The DAPA CKD versus Credence, well, this was now for patients with or without diabetes. The DAPA CKD was for the first time done for patients with or without diabetes, showing basically a tremendous reduction in all composite renal outcomes, alongside with that in a total death as well. This was not something that was visible, the total death outcomes in the Credence trials, which were patients with diabetes only, basically showing that the use of this drug can be done in patients even without diabetes with good renal composite endpoints. The
Not
ADA
only
standards of
one
medical
thing.
care have now changed, where basically we say that after the use of metformin and lifestyle, the first question to ask every patient is that if they have high risk of established ASCVD, CKD, or HF, the first drug of choice is going to be a GLP-1 RA or SGLT2 inhibitor. If there's a compelling need to minimize hypoglycemia, same story, both these drugs in the first rung. If in case there's a need to minimize weight gain, again, these are the drugs in the first rung. Cost, I would say, yes, these are expensive drugs, not possibly useful for every patient in India, given our economic issues. But if you put in perspective over here that the reduction in complications that these drugs can achieve, well, I think it is a rethink that if we use these drugs early on, are we actually benefiting the patient even economically in the long run? And this is, again, just a snapshot
Can you
of
summarize, ma'am? Yes. Can you summarize?
Sure. I'm on the last slide over here. Just now, the SGLT2 inhibitor, basically the ESC recommends the management of early in the course to decrease CV and total mortality. These are the indications of all of these. Finally, what we've seen right now is that the SGLT2 inhibitors basically are covering the entire cardiorenal heart failure outcome. And probably this is something for all us diabetologists to learn a little more cardiology, cardiologists to learn diabetology, all of us to learn about nephrology as well, because this is probably all one single disease, the cardiorenal diabetes hybrid, as I would call it. Thank you very much.
Thank you very much, madam. This was a very good presentation. Only 20 minutes, you could cover so many
I'm
things.
sorry, I was way too fast.
Yes. Because of lack of time, we may not be able to take any further questions.
Sure.
The participants are requested to ask her the questions directly. We can move on to the next session. Over to you, Dr. Saraf.
Thank you, Mukund. Thank you, Dr. Pia Balani. It was a very concise and a good talk. Bhavik, we move on, please.
Yes, sir. So for the next talk, we have Dr. D.V. Kadam, sir. He will be talking about post-COVID management. For this, I would like to call upon Dr. D.K. Mahavarkar, immediate past president MAP, past president API Thane, chairman financial committee MAP, senior physician and director of Mahavarkar Hospital in Thane.
Hello.
Over to you, sir.
Hello.
Yes,
I can hear you, sir.
You can hear, no?
Yes, sir.
Yes.
No, you cannot start your videos like because something is coming like this. Okay.
So we can hear you, sir. You can go ahead.
Okay, then I'll start. Dr. D.V. Kadam is a professor of medicine, SKN Medical College, Pune. He is, chairman for the task force COVID-19 Pune, and he is professor emeritus of Vijay Medical College, Pune. And I heard him many times in our eMAPCON with swine flu presentation, which earlier started in Pune, and he is a good academician. He is good in studies like swine flu as well as COVID. So I request him to start his presentation. Dr. D.V. Kadam.
Hello, good evening, everybody. I will just try to share my screen. Okay, so today, first, many thanks to Executive Committee of MAPCON, Dr. Devavakar, Dr. Amit Saraf, Mahavarkar sir, for giving me this opportunity to talk on post-COVID management protocol. And if we look at this particular disease process, as has been shown in the earlier lecture, it's a 3 weeks disease. The first week fever, cough, myalgia, second week hypoxia, and third week ARDS, and followed by fourth week recovery. So this 3 weeks disease can lead to further complications. BMJ defines post-COVID disorder as any disorder which occurs after 3 weeks, while JAMA says it's acute if it is in first 3 weeks. 3 weeks to 3 months is subacute, and 3 months onward it would be a chronic post-COVID disorder. Now, if you look at the numbers infected in Maharashtra, almost 16 lakh people have been infected till now. If you take 5 to 10% of them will develop post-COVID complication, still the number is pretty huge. So we have to look after these patients, and this surge has to be managed well. So we will be considering this topic as discharge summary and then systemic approach of each one of them. If you look at the discharge strategy, mild cases, as we discharge them on day 10, we need to follow them up for next 15 days for any post-COVID manifestation. The Jaipur patient was discharged from CCC and he stayed in a hotel, and within 48 hours, he was found dead due to myocardial infarction. So such things have been noticed and declared in press also. So we need to follow them by telemedicine, and even if the patient is in home isolation, he should be monitored with pulse ox, temperature, and other features. Moderate cases, they have evidence of cytokine storm. So at the time of discharge, cytokine storm investigation like ESR, CRP, ferritin, D-dimer, LDH should be done, and to ascertain whether there is a stoppage or still persistent cytokine storm like situation is present. Review exercises, HRCT would tell you the exact score with which the patient is going home. Radiological clearance will take time up to 3 weeks to 3 months, so that we should keep at the back of our mind. DLSO is ideal but will not be available in many centers. PFTs to rule out any ventilatory defect should be done, and 6-minute walk test is a must at the time of discharge. In severe cases, in addition to what we have done in moderate, we need to look for multi-organ failure, like LFT, RFT, CPK, HbA1c, uric acid, and other investigations. The first follow should be there at the end of 1 week for all moderate and severe cases, and depending upon patient's condition, we should follow them up at least every 14 days for first 3 months to prevent any onset of post-COVID disorder. In mild cases, it's mainly psychological and social handholding will be needed. In moderate and severe cases, other evaluation and other system help would be needed for these patients. If you look at this particular intern who is 26 years old, posted in our hospital, did COVID duty, got infected, went home. This grandfather got infected and he succumbed. Now this intern is having guilt feeling. He even attempted suicide for the same. So such type of things can occur in a mild patients. So psychosocial issues, mainly insomnia is present in most of them. And anyone who has that typical headache of COVID, with the patient will describe that 20 kg helmet is kept on his head and he is unable to remove it. Depression is the next one, which is common. And this is seen in such patients who have this headache as the presentation. Episodes of mania can also be seen and should be addressed to. Psychiatrist help is needed, but what is more needed is clinical psychologist than psychiatrist per se. Now, this another 65-year-old patient got admitted in 13/8, was in moderate to severe disease, was treated, discharged on 21st of September. Again, after 10 days, he came back and again he had dyspnea. So he had recurrence of pulmonary symptoms and then again was put on ventilator. So such type of pulmonary complications are common if the score at the time of discharge is around 15/25. Exertional hypoxia or persistent need of low dose oxygen will point towards such type of lung manifestation. Abnormal 6-minute, but most of the time we do 3-minute only. High D-dimer and ferritin will be indicative of this. So these patients would need antifibrotic drugs like Perfenix, nintedanib, low-dose steroids, and apixaban for a period of 3 weeks to 3 months. So that this should be considered. In a patient who is tracheostomized, we need to look out for tracheal stenosis, presence of dysphagia, tracheoesophageal fistula additionally. Immune-mediated complications, though, are less in number, but we have to keep a watch on it. It's now called it as multisystem inflammatory syndrome, specifically seen in pediatric age group, which is termed as Kawasaki disease in past. And is a classical example. We have seen it more in adolescent age group than a real infant or less than 5 years of age. The systemic vasculitis can give rise to multi-organ failure-like presentation in adults. More common is post-COVID Guillain-Barré syndrome. But if you just check your hospital statistic, you will also realize that suddenly Bell's palsy incidents have gone up. And if you do IgG for COVID, many of them will show presence of IgG. So Bell's palsy can also be a presentation of immune-mediated complication. And what we have seen in our institute is variety of skin manifestations, right from angioneuritic edema to multiple rashes during the duration of 6 weeks. Fortunately, they respond well to low-dose steroids. IVIG and plasmapheresis will be reserved for Guillain-Barré syndrome. Thrombotic complications can give rise to post-COVID DVT, which is the commonest one, followed by AMI and stroke. But stroke need not be only the thrombotic, it can be hemorrhagic. One of my friend developed post-COVID the intracranial bleed and died because of pontine and midbrain and cerebellar bleed. The high D dimer at the time of discharge, these patient needs to be keenly observed. Today only one father of a civil surgeon was discharged after post-operative status of fracture neck femur with COVID positivity. He went home with the D dimer, which was more than 10,000, came down to 3,000, again went up for more than 10,000. So that gives an indication that such patient is likely to develop thrombotic episode. And again, this needs to be treated by NOAC for longer duration of time. Now, this patient got admitted with corona positive, lungs looks pretty okay, developed pleural effusion, was tapped, turned out to be transudative, but her ejection fraction was only 20%, and this was 4 weeks after her presentation. So she had additionally paresthesias. The nerve conduction showed axonal sensory neural polyneuropathy. So patient need not have florid pulmonary picture, but can have other system manifestation. When we repeated her to the echo after 8 weeks, then all the functions had came back to normal, but she needed in between the supportive therapy, decongestant line of therapy, and with that the therapy for neuropathy. So this also we should keep in mind. So she had post-COVID myocarditis leading to cardiomyopathy-like picture, which got reversible after that. Neuromuscular complication, the post-COVID neuropathy and myopathy have been described. The CPK, if it is high, would lead to myopathy with proximal muscle weakness. The important is post-COVID viral fatigue syndrome. And most of our patients are a doctor themselves. They say that it is difficult to sit up from a lying down position. That degree of weakness and proximal muscle weakness they have. Nerve conduction studies are essential to rule out additional critical care neuropathy. But they do respond well to combination of our carnitine, vitamin D, calcium, selenium, and cofactor Q10. Next important issue is comorbid management. So most of these patients are elderly. They have had diabetes, hypertension due to infection, autonomic imbalance, and steroid therapy. Both of these things become worsen, and close monitoring of blood pressure and blood sugar is required. Unmasking of diabetes or stage diabetes is also noted, which will need treatment after the corona is cured. Antidiabetic therapy and antihypertensive therapy should be titrated depending upon response of the patient, and comorbidity should be looked for carefully. Next one is worsening of CKD. The patient comes up with creatinine 2.6, develops AKI due to COVID, and then creatinine jumps to somewhere around 6-7, and then goes on to maintenance hemodialysis. So if the patient has underlying CKD, additional AKI due to COVID definitely worsens it and needs to be monitored closely for this. In the PLHIV patient, one of my general practitioner friend who is on ART. He had a CD4 count of 856, developed COVID and dropped down to 176. So sudden depression will present as onset of secondary infections like herpes zoster and others. If that is seen in a patient who is on ART, please suspect associated COVID and COVID related late complication due to depression in CD4 count. Drug-related complications like the remdesivir-induced hepatic dysfunction in a patient who has underlying liver disease or favipiravir-related gouty arthritis and management of the same will be needed in post-COVID period. Physiotherapy is needed for all these patients, and breathing exercises, respiratory physiotherapy is the most important thing which we should teach these patients before discharge. The others, but which are most important, is weight loss. Weight loss, if you look at your the records, the moderate and severe patients lose average 7 kg weight. One of my patients who is financial advisor was 110 kg on admission and was 70 kg at the time of discharge. A severe weight loss is a feature of this disease, and dietary management with adequate protein calorie supplementation, it takes around 3 months for regaining of whatever weight they have lost, and this weight loss is associated with excessive fatigue. So this we need to manage during post-COVID period. But don't forget reinfection and co-infection. Reinfection, there are a few cases, but they can present with more severe disease, and co-infection like associated dengue or associated the occurrence of H1N1 pneumonia can make them present again in post-COVID period. That has to be at the back of our mind. So once we know this, how do we manage these patients? The plan of action should be, we should have a post-COVID OPD running in our hospital, and this OPD should be managed by medicine, respiratory medicine, psychiatry department with clinical psychologists, physiotherapists, and dietitian. The first will collect demographic data of the patient. Age, obviously elderly age group is more common. Sex, 65% of our patients are male, rest are female, but the same distribution was there when the patient was admitted. Occupation, especially occupational lung diseases patients, will figure bad in this.
So 5 minutes left.
Yeah, I will be able to finish by that. The details of COVID-19 infection, we must know how many days the patient was admitted, what was the oxygen requirement, how much was the weight loss in this particular patient, what was the HRCT score at the time of discharge, X-ray chest and number of zone involvement, and importantly, other system involvement during acute stage so that we can follow them up well. And comorbidities, the predominant comorbidities, and whether there was change in the comorbidity status due to added COVID infection. To evaluate symptoms, the insomnia by far we have seen is the most common, and next one is the fear factor. This is the COVID psychosis leading to checking of the pulse oximeter reading every 2 hours have been seen in medicos. The social withdrawalness and social depression is the next one. In pulmonary, we all know dyspnea and exertion, fatigue, dry cough is the most common. Bronchospasm is less common in these patients. The skin rashes, paresthesias for immune, thrombotic, the DVT, neuromuscular chronic fatigue syndrome is the one which should be looked for specifically, and drug-related and comorbidity-related symptoms should be looked for. Psychiatric evaluation, each hospital can have their own psychiatric evaluation questionnaire. This is the one which we use, and we ask specific questions regarding underlying irritability and underlying depression. So this is a 3-page the psychiatric evaluation. Then you evaluate for vitals in this patient, including weight and BMI and signs of cardiac and respiratory failure. And then systemic examination should be carried out by keeping close look on post-COVID manifestation related findings. So if you have such a type of proforma, you can just tick mark whatever is present and whatever is absent. Investigations, obviously, we need to do cytokine storm related investigation, and then the system specific the investigations will be needed depending upon patient's presentation. Management will involve mainly dietary management. Fluid intake must be maintained. The diet should be of 2,500 to 3,000 calories with enough protein supplementation. The fluid intake should be around 3 to 3.5 liters per day if the patient has developed gout or patient had AKI during this. The physiotherapy is mainly breathing exercises, aerobic training, strength training, and home-based programs for physiotherapy should be taught. In drug management, mood stabilizers, the sertraline has shown good effect with us. We use sertraline for most of our patients. Antifibrotics like perfendinon, the steroids, anticoagulation, and they need it for 3 weeks to 3 months duration, depending upon their D-dimer and ferritin level. Home oxygen therapy was needed, but these patients, they do get readmitted. The 50% of our home oxygen therapy patients got readmitted within next 1 month because of worsening of the status. So this has to be kept in mind and explained to the patient well. Micronutrient supplementation is needed, and specific therapy for any other system will be put forth depending upon the complication noticed in these patients. So that's how we can manage these patients with post-COVID. But remember, post-COVID can kill a patient. I have lost 2 of my close persons, one with worsening of pulmonary manifestation and second one with IC bleed. So we have to keep a close look, and at the time of discharge, we should give detailed instruction and counseling regarding post-COVID management and when to come and when to approach and whom to approach. All those things should be told to the patient at the time of discharge. And this is how we can keep the follow-up of weight, BMI, saturation after 3 minutes, 6 minutes walks, and the inflammatory markers every 7th day in a patient who is showing abnormal the thing at the time of discharge. Right. So that are the things which I need to talk about post-COVID management. Are there any questions on this?
Yeah. Thank you, Dr. Kadam. You have given very simple and nice way of post-COVID presentation.
Sir, I got a question. Sir.
There is one question.
Sir, I got a question.
Okay.
Yes.
Sir, Kadam sir, in your actually you are looking after COVID patients in Pune and you are in charge of this COVID task force. How many patients of reinfection you have seen in your clinical practice, and if they are there, how you are treating them? Like previous patients, they were treated like same way we are treating them, or do we have some different approach?
The reinfection in Sassoon, they had 3 patients who were positive, became negative. 2 months down the line, again became positive. But all of them, they responded well to the therapy with remdesivir. One patient right now is admitted in Noble, who was detected to be positive in the first week of August, was treated. Then again started getting symptoms in first week of October, and he has the moderate to severe pulmonary disease and needs NIV right now. He's also received again the convalescent plasma and remdesivir. So the treatment factor remains the same. In the patients with reinfection, we had requested NIV to look for genetic of both the things, but there was no difference than the previous virus. So maybe the patient had negative report and again turned out to be positive. The coronavirus, we say as a standard, after day 14, patient doesn't remain infective, and whatever positive report you get is because of dead virus. May not be true in all, and most of the general practitioners are giving left and right steroids, which may result in poor clearance of coronavirus, and which we might label as a reinfection. That was another thought to it.
Incidence is high.
Sir, is there any role of antibodies
Hello.
during recovery? Is there any role of antibodies like IgM, IgG? When to do it? Should it be quantitative or qualitative? Because quantitative, nobody.
Basically, the IgG antibodies, the protective level depends upon which method you are using. The one which we had in our hospital was the titer of 1 to 840, but they hardly ever we see that particular titer. The study which was done by ICER, they showed presence of IgG in around 50 to 65% patients in the slum areas where titer was low, and we haven't done repeat titer after 3 months. The outside studies showed titer declines fast after 3 months, and protective immunity is less likely to be present in these patients because of two reasons. This particular virus deals with mainly cellular immunity than humoral immunity. So T cell the activation is more than the B cell activation. That leads to less of antibody formation and less in protective titer. That is one thing. Secondly, the steroids which we give as a mainstay of the therapy, the steroids which we use for moderate and severe cases may lead to reduction in formation of humoral immunity. The study was done in mild, moderate, and severe. The IgG levels were more in moderate and severe, but mild, only 21% had IgG to the tune of protective thing. So doing IgG and IgM for patient's sake is of no use, and this IgG and IgM was done as a part of plasma therapy trial. So that's why we could come to know that many of them do not develop a protective. The mild cases hardly ever develop any protective antibodies. The protective antibodies are seen in moderate and severe, but because of use of steroids, again there is a limitation to it.
Sir, injectable antibodies are there in US. They are making available because the president of US, they got injectable antibodies. Is it
so basically what they are trying to do is to get this antibody from horse as an passive immunity. And secondly, the studies are going on onto the collection of the blood and then refining IgG antibodies and then use that as an injectable thing. The way we use IVIG or anti-tetanus or anti-hepatitis. So that type of things they are being produced and used commercially.
But if
Thank you so much, Kadam sir. I think we will have to.
Good results. Why it is not used so commonly?
Which one?
Because president of US become all right in 4 days.
No. The thing is that it depends upon whether he had mild disease, moderate or severe. But he did receive remdesivir, and all of us know that if the patient has fever for more than 48 hours, if you give remdesivir, patient becomes all right within 24 to 48 hours.
Okay.
Thank you so much, Kadam sir. It was a very lucid talk. Mahavarkar sir.
Now I hand over to you because the last lecture is there. You are the chairperson, so take over.
Thank you so much, Kadam sir. Bhavik, can you have the next slide, please?
Yes, sir. Sure.
So with that, we come absolutely to the fag end of today's day. It's the end last topic, but I thank everybody for being there. I was watching the YouTube counter, and we crossed around almost 350, 400 delegates watching on the YouTube as well. So that's a big achievement, and I'm sure this August gathering here will also very enthusiastically listen to the next topic, which is delivered by a close friend of mine, Dr. Rohan Sikwera. He is the head of unit of medicine in JJ and Grand Medical College. He's been director at the Kambala Hill Hospital as well, director at the Sachurusha Hospital in Dadar as well. He is a founder and a director for the ClinicJect software for app as to be used in patients. So Rohan, it will be a pleasure to listen to you today because you're talking on an extremely relevant topic in the current times about telecommunication, teleconsultation, how relevant and what is the way forward. So I welcome you, my friend, and floor is all yours.
Thank you so much, Dr. Amit Saraf. First of all, I want to thank all the delegates over here, and I want to thank all the organizers who have given this opportunity. Sorry, I've just come from the hospital, so I look like a freak right now, but then we're all in difficult times in this COVID. So I'm just going to share my screen right now so that I can present the slide. And I'm just going to share some of my own experiences also, what we've been facing and how we have transitioned as a company. So yes, my name is like my dear friend Dr. Amit Saraf has said, my name is Dr. Rohan Sequeira. I am cardiometabolic physician. I am also at Just Look and Rich Candy, and yes, so I am the founder and CEO of Quera Technologies LLP. Now, today I'll be talking to you from two sides. I'll be talking from the medical side as a doctor with about 30 years of experience, and also as a 5-year experience of running a tech company. So, I'm going to be looking at both sides of the fence. And it's been an interesting journey because Clinic Jet, what we call our company, is basically taking your clinic into the cloud. And it's come from a lot of experiences over different countries, working in the army, working in private hospitals, working in government hospitals, working in the public sector, in different areas, in corporate sectors. So this has come to an amalgamation of everything. So just to give you an introduction, I'm not going to go much into the introduction of telemedicine because I think Dr. Shivkumar Utture earlier has given a fantastic deliberation on what telemedicine is, what are the aspects, what are the future potentials and everything. So if you want to know more about telemedicine by itself and the laws pertaining to it, you just have to rewind the slide to when Dr. Utture spoke, and I think you'll get a fantastic lecture on that. So what telemedicine really is, actually, I would like to call it, is a new frontier in clinical medicine. And it's been about 4 years since I formed this company, clinicjet.com. And not only am I consulting patients every day, seeing them all, we're also running this company because, it's both of them are equal passion projects of mine. I love medicine and I love the way medicine can be delivered into patients' home. And that's the reason why we started this company. And I think telemedicine, if you look at ourselves as physicians, we are all physicians over here. If you look at ourselves, we all rely on tools. I think the last best tool that we ever got was a stethoscope, which was discovered and invented by Lennec. And I think telemedicine today is the new tool that we have to breach this new frontier in clinical medicine. The question everybody asks every day is, can this telemedicine or telehealth be used to improve access to patients and give them evidence-based clinical services right at their doorstep? And I think the answer everybody knows is yes, it can. It has the potential to improve access to healthcare across populations. Now, every day on my platform on clinicjet.com, I have got hundreds of doctors who are using this platform. We are consulting patients in areas where there is absolutely no facilities, but there is an internet, because today internet has been penetrating into the deepest of interiors. I have consulted patients who are living in villages, in Assam, in Northeast India, all over the places. And patients are realizing this, and they are actually asking doctors to use telemedicine when they are not able to come to the clinic or to the hospital. And yes, it is working very well all over the world. And now the government has legalized it in India. A few beneficial effects of telehealth is it's a technology. It's basically extending your service and my service as a doctor right into the patient's house when the patient is not able to come to me, or the patient prefers to have a follow-up at home. And as physicians, we know that, it's the first visit, which is the most important visit. We do all our assessment, we do the examination, we do the lab reports, we ask the patient, we check the patient. And usually as a physician, most of our consults on a day-to-day basis are usually follow-ups. And that's where telemedicine actually scores over the surgical fields, because a surgical field actually requires a right in clinic examination at every point of time. But when you look at it from a physician's point of view, telehealth and telemedicine, if used effectively, and that's what we are doing every day, actually makes a lot of life easier, both for the doctor as well as for the patient. And this is very, very prevalent and very, very important to understand, especially during this COVID time and even going ahead. So I'm just going to give you a few brief overview of what ClinicJet is, how we decided to make this, and how many. So ClinicJet basically is a company which is run by doctors for doctors. It's not made by some IIT, IIM, or somebody who decided that I'm going to fix one problem. What we look at is we look at telemedicine as a whole. We are all doctors who are making it. All of us are, there are about 15, 20 doctors who are part of the advisory. They give inputs from their day-to-day practice, and all of that is being included into the entire process flow for how you practice telehealth. And that's one of the reasons why we have been successful quietly, but growing steadily. We have had a 400% growth in the last 4 months itself. So that speaks a lot of volume for what we do and what we stand for. So the takeaway from this previous discussion, what I had, is that it has a tremendous potential to expand your access, to reduce your costs, and to improve the quality of care. Now, What should a platform contain? This is a very important question. First and foremost, data security is the prime thing that a platform should contain. Now, it's coincidentally that I'm also on the National Committee for the Data Security to the Government of India. We have a platform which actually advises the Government of India on what are the data security measures to be taken in a telehealth platform. And we have been advising the government, and you'll see new policy changes coming out in the near future, which will basically contain a lot of features for data security, because as a doctor myself, I do not want my patient's data floating around for some other company or third party or someone to use. As per the teleconsultation law, the data belongs to the patient, and we as doctors and the platform are only caretakers. So for every data that is going to go outside, whether it's identified or de-identified, you need a consent from the patient. So that's where data security comes. A platform should be truly mobile. You should be able to use it anywhere, anytime, any place. And the patient support interface is very important. What we don't realize in India, maybe see in the US and in the West and in most of the developed countries, patients are very tech savvy. They know how to use mobiles, they know how to use this, they know. We as a country in India, now if you look at each of our own families, we have so many members in our families who do not know how to use an app, or they would get intimidated using an app. That's where we brought in a call center. This call center handles all the calls for patients, because we as patients, as elderly patients, as patients who are sick, want to talk to a human voice. That's where the call center comes in to handle everything, right from the registration to the payment to the follow-up to the problems with the platform to everything. Each and every aspect is taken care of by the call center. And that's one of the reasons why ClinicChat has had a fantastic patient satisfaction index so far. We don't do data sharing. Absolutely not. Never done it in my life. I'm sure none of us want to do data sharing. A drug database is what we have. And I think the drug database, we have about 180,000 drugs, and it's always growing. All our drugs are both brand and generic specific. We have 80,000 investigations. And even if there are new drugs and new investigations coming out, you can always add it. You can do a referral service. Plus, we have specialty specific case sheets. That means a diabetologist will get a diabetes case sheet, a physician will get a physician's case sheet, a surgeon will get a surgeon. So data flow becomes very easy. Plus, co-consultation is something that nobody else in the country has got. That means, for example, if a patient in Dhule is visiting his general practitioner in Dhule, and that patient needs a consultation from a doctor in Bombay, the patient can actually book a co-consultation by calling up the call center. That means the patient will call up the call center and say, I want my doctor to speak to the doctor in Bombay for a second opinion, and both the doctors should be online, or maybe I'm in my doctor's clinic. We are the only company today which is doing co-consultation, and it's been doing very, very well, especially for secondary opinions from tier 1 and tier 2 cities. Now, what is ease of workflows? Ease of workflow is, as doctors, now over 20, 25, 30 years of practice. Some of us here in this audience are, I think, more than 50 years of practice. My due respect to them, is we all have had a flow. We have a pattern of workflow in our clinics. This platform actually has copied a lot of that workflow, because there are 15 to 20 doctors who are advising the platform on a continuous basis, and each in their own specialty. Now, this is something which really helps a workflow. Plus, we have a functionality called repeat all, because as physicians, we know that the first case sheet is the most important case sheet that we create. So we are coming up with speech to text, where you just speak and it types automatically for you. Or if you are diligent enough, you can actually write down the first case sheet. And on the follow-up, there is a button on the first case sheet that you just click called repeat all. The system automatically pulls the entire case sheet into today's case sheet, and all you do is minor adjustments. Your new case sheet is ready in less than 2 minutes. And it's very, very similar to the CT all that we usually write in our case sheets. So that's what we have brought into the system to make life easy as we go on. Plus, it works across clinics. Let's say I'm practicing in 7 or 8 clinics and I've got 2 hospitals. The system follows me wherever I go. If a patient from one clinic comes to the other clinic, the patient's case sheets follow. So everything is floating in the system, and everything is accessible at any given point of time. Plus, we have customized templates. So if you feel that you're seeing more of diabetes, more of hypertension, you can actually create a template. It's a one-time job. You just create a template, and anytime a patient, for example, if I create one diabetes template, I create a hypertension template, or if I create a maybe thyroid template, or if I create a metabolic syndrome template, if I find a patient, I just select the template, just do the minor data, and the case sheet is saved. Plus, I can add drugs and investigations anytime for myself. Medico-legal aspects, we are audited by two companies which basically look at all the medico-legal issues. We have been in discussions with the Institute of Medicine and Law, which is a body comprising of doctors, lawyers, judges, and all civil servants. So we are getting audited consistently at all times. Plus, every consultation that takes place, a patient has to click a consent form, and it says that I, patient so and so, agree to consult with Dr. Rohan Sequeira on this platform, and all the entire format is as per the MCI and the NMC guidelines.
So 5 minutes left, please.
Yeah, so I'm just going to finish this first. And also we are compliant with the Telemedicine Act of 2020, EHR guidelines of the Government of India. So I'm just going to go security, highly secured. We have got HIPAA server compliance, military grade encryption, cyber security verified. Very, very easy to use. I would say even a 10 or 15-year-old child would be able to use this very effectively. Highly customizable, and it's an all-in-one solution which we have come out over the last 5 years. It's taken a lot of time, but yes, we have managed to make it into an all-in-one solution. Ultimately, we have the national call center, where any patient of yours, if you're registered on the system, all you have to do is put your fees, put your timings, the patient calls up, fixes up an appointment, the call center handles everything. You don't even need a secretary. In fact, even when your clinic is shut down, the call center will be able to take your appointments for your patients. Now, when you come to the price, everybody wants to know about price. Yes. So very happy to tell you that we are completely free. Absolutely free. Now, everybody is going to, first question that's going to come is how do you make money? Okay, what we do is we have kept all the features of ClinicJet absolutely free of cost. The only place where we do a transaction based on the thing is, let's say we do a 10% deduction from your consultation fee if you use the teleconsult module. If you use the EHR, if you use the electronic health record, there is absolutely no cost. Even we cannot see your data. Your data can only be seen by you and your patient. Even it's encrypted, so we can't see. But we only charge a 10% deduction on your teleconsult. So if you do a teleconsultation, we do a 10% deduction, which is very similar to the OPD affiliation fee, what you see in all the hospitals. Because yes, it does take a lot of time, effort, energy, and money to run the service, to give you video servers, to give you access to all your systems. So that's a very fair price to pay. And we are one of the lowest charging platforms in the country as of today. So what do patients want and barriers to telehealth? So we all know that the fear of using online systems. So we have a very, very strong call center which handles all your patient queries. Even if doctors have problems, you can call up the call center and they will guide you to medical specialists who will be able to onboard you and take you on very easily. So to conclude, I think in the next few years, we are going to see an explosion of services coming out with teleconsultation. And what do you look for in a platform is maybe someone who has designed a platform, who understands the need of the medical community. See, the patient is the recipient, he's not the user, primary user. The ultimate primary user is the doctor. And that's where I think we score over a lot of other companies, is because we are a group of doctors who has made it for doctors, and it's a collective experience of the last 50 to 60 years, which has gone into the development of this system. Plus medico-legally safe, highly secured, and completely mobile. So I would like to bring this phrase by Amrish Puri, the great actor who is one of my favorite actors. He said, "Jahan meri awaaz pahunch sakti hai, wahan meri goli bhi pahunch sakti hai." Now, unfortunately, he spoke about a different goli, but we are talking about the goli in the sense of medicine. So I think telemedicine really applies to this statement of Amrish Puri, "Jahan meri awaaz pahunch sakti hai, wahan meri dawai ki goli bhi pahunch sakti hai." And I think this is where we are going. And I think even if we do one teleconsultation a day, it adds up a lot, not only for the patient front, but also as your front, you are able to reduce your workload in your clinic and you can consult the patient whenever you want. So at the end of this, thank you for the wonderful lecture, the opportunity to speak. If you guys ever need anything, we are always available at clinicjet.com. Definitely made for doctors, by doctors. I still use the system. I've seen we have more than about 3,000, 4,000 patients myself on the system. And we have got hundreds of doctors using it. And we have done a lot of consultations so far with a 98% success ratio. So thank you. And very soon we are also going to launch across India. And we are already actually launched across India. We are launching now very soon in Africa and Southeast Asia. But I think India is my home. And this is where I would like to go local for global. Thank you so much for this opportunity to present, and it's if any one of you has got any questions, you can always visit our website clinicjet.com, and I'm always available to help you.
Rohan, that was wonderful. Thank you so much for a very like in time kind of presentation. Finished definitely in time. A presentation which was very apt for the need of the hour kind of scenario, and it's really good. I mean, I can share with everybody here. I've used ClinicJet myself, and it's absolutely, as he said, very user friendly, extremely good, very sort of customizable to our local need, and very good support. I think he's done well. I guess I think Rohan, you were the last batsman of the day.
Yep, I was about to say that.
Amit, I want to ask a question. Can I?
Yeah, sure, welcome, sir. Please ask.
See, my question is, the speaker has told that he's making separate templates for hypertension, diabetes, and other things than surgical. But as a physician, when we see a patient, he has many such disorders. I will be seeing a patient who has a thyroid disorder, who has hypertension, who has diabetes, who has ischemic heart disease. So do you have a separate template for that? How do you do that?
Yeah, I got a question, sir. So we have two different, it's very flexible. You can actually choose to use a template, or you can use the regular case sheet flow as it is, as you would normally see a regular case sheet flow. So if you have a patient who's got multiple complaints, say for example, I can understand your point because I see the same kind of patients. So sometimes I choose to use a template if the patient fits that kind of a category, but otherwise I can use the regular patient, the case sheet flow to do a regular case sheet the way I would normally do in my clinic.
What about writing the case records? Can we write on with the pen? They can be transmitted to there, or we have to type?
So as of yet, we have not enabled that feature, but that is coming out in the near future because that has been a request. So we are constantly learning, I have to juggle, we are constantly learning from consultants like you what is really required. So that has been one request which we have seen where you can write a case sheet and upload it, and even that will be part of your medical record.
Yeah, one more thing.
Yes, sir.
See, many times what I've seen is I have consulted few number of patients, 50, 60 patients during pandemic, but I was fed up because patient takes so much time. They go on calling often. Does it happen to you?
No, sir.
Stop. Then how do you work?
So what we do is, so basically what I do is, we are actually trying to avoid the entire saga of patients doing the WhatsApp. So we have a call center. So if any patient has got any issue, they usually call the call center who directs them to our to your clinic's secretary at the particular time. So they don't get to disturb you. And at any given moment of time, if the patient wants to consult you, they have to go through the call center who takes care of all this nonsense. Because I
have stopped doing video consulting because of that. People go on making n number of calls.
Yes, sir. Actually, that is the problem. That's what happens when people use WhatsApp or FaceTime or all those other kind of modalities. So we are coming out with a system where all of this WhatsApp consultations, because the moment patient sees you online, you get 15, 20 requests. Sir, I got temperature, I got this, I got that. I'm sure even Amit Saraf has been having the same problem. Everybody asking. So everybody looks for that online. So we are removing that entirely, and we are building a system in place where patients can send a chat message on ClinicJet, which is coming very soon, but they will not be able to see you online. So if you feel you want to reply to them, you can reply to them. Otherwise, you can direct them to the call center and say, take an appointment.
Once you develop that, let us know. I'll be again restarting that.
So it's currently under work, sir.
Yeah, particularly used for follow-up and seeing reports about patients which you have seen.
Right, sir.
Thank you very much. It was a very nice presentation. I really loved it.
Thank you so much, sir. My pleasure. Thank you, sir.
That was the former president of API Thane, Rohan, Dr. Prakash Bhatkamkar, a very senior physician from Thane.
Okay.
I'm glad that he showed a lot of interest in this new age technology. So thank you.
I've been doing video consultation for the last 5 months. I was fed up now.
More time consuming.
Thank you very much.
Sir, to be very honest, we are all fed up. I think all of us on this platform here have the same issue of 1,000 messages a day and all that. I know because I spoke with Amit, and Amit Saraf was telling me about WhatsApp becoming like one door without a door. It's just everybody is getting access directly into your house. So we need to address that.
Thank you so much. Yeah.
Right.
On
that note,
I will join your group now. ClinicJet.
Amit.
Yes, sir. Marker, sir.
Thank you.
Thank you. Today it was a very busy and nice day. We enjoyed each and every lecture, including last lecture, which is very interesting. So, Amit Saraf, you can just say last few words for today's.
Amit, congratulations. You did a wonderful job. Really, it's very difficult to maintain the timing. We have finished at 8:40, means 8:40. This Ionet not seen anywhere. Really great.
It is all because of
NK Singh, no? NK Singh also appreciated that this is the first webinar which is going on in the correct timings.
It's all of you to thank.
On the dot.
No, it is always a team effort. I have all of you to thank for it. This is what is MAP all about.
I believe
Amit, for tomorrow's link, you can send it today.
Yes, sir, I will. Joshi sir, I will.
I'm the first opening batsman, so
I will send
it.
Amit, I think there should be some on-time Puraskar which we can give you, because honestly, I agree with everybody, even Devgaonkar sir and everyone.
तू मेरे को एक Saturday evening का bottle भेजेगा तो हो गया रे रोहन, और कुछ नहीं.
मैं टैंकर भेजता हूँ, don't worry.
Me and Rohan were together at JJ, so I can say that to him. Anyways, thank you everybody. It was a wonderful session this day. I wish you all a wonderful weekend. I wish to see you all tomorrow morning at sharp 10 o'clock. We begin for the second day of the eMAPCON 2020. And thank you so much for logging in. It was a wonderful time we had today. I'm sure we all learned a lot. I'm sure we all had a great time with each other after a very, very long time given the pandemic. And I hope everybody here on this group and their families remain safe. And I hope to see all of you. And I hope to shake hands with every one of you in the new year when we have a physical conference. Thank you so much. Have a great night.
Okay. Have a good night.
Thank you. Good night.